The committee will come to order and welcome. We are holding today's hearing in a hybrid format in compliance with the rules and regulations for remote committee proceedings pursuant to House Resolution 8. Before we begin, I want to remind members of a few procedures to keep these proceedings running smoothly. First, consistent with regulations, the committee will keep microphones muted to limit background noise. Members are responsible for unmuting themselves when they seek recognition or when recognized for their 5 minutes. Committee staff will mute members only in the event of an inadvertent background noise. Second, when members are present in the proceeding via WebEx, they must have their cameras on. If you need to step away to attend another proceeding, please turn your camera and audio off rather than logging out of the platform. Finally, consistent with revised guidance made by the Office of the Attending Physician, all members and staff are required to wear a properly fitting mask to significantly reduce the spread of Omicron. A KN95 or N95 mask falls within this guidance. Let me now turn to the topic today, America's mental health crisis. Welcome to the Ways and Means Committee hearing for the second session of the 117th Congress and the committee's first hearing on mental health in more than a decade. For far too long, Americans have shied away from conversations about mental health, contributing to the deeply held stigma about seeking care. While we've made great strides in recognizing the importance of caring for our mental health as a society, it's appropriate for Congress to act. Before the pandemic, 1 in 10 American adults reported symptoms of anxiety or a depressive disorder. Since then, that rate has skyrocketed to 4 in 10 adults. There's no denying the pandemic has exacerbated the mental health crisis, and we will hear today of its effects. On top of life's typical triggers, people are now in the position of having the fear of contracting COVID-19, which means prolonged social isolation, the stress of uncertain or unpredictable childcare, and the anxiety of losing a job and economic security. For health and human service workers and other essential workers, this trauma has permeated their entire lives as they deal with the effects of the pandemic at home and at work. The added stress of being overworked or short-staffed is pushing many Americans to their limits. This provides a crisis on top of already a crisis. And the impacts are not only felt in our personal daily lives, but also in our economy. For those seeking care and taking care of loved ones, lost earnings due to serious mental illness represent an estimated $193 billion each year. On top of this, we hear far too often about the difficulty constituents face in accessing services to address their mental health needs. From being forced to wait months for an appointment to the challenge of finding in-network providers, the current state of our mental health care system is unacceptable. The workforce hasn't been able to keep up with demand, and insurance plans haven't expanded enough to include this crucial care, despite long-standing requirements and the really good work that Congress has done in the past. There's no single solution to strengthen the system, but a good starting point is building provider capacity, not only to meet overall demand, but also to better address the needs of our diverse patient population. The Pathways to Practice program contained in legislation the committee marked up last year would help build a diverse physician base that receives the necessary training to appropriately care for the diversity of need across our nation. The growing mental health challenges only add to the need for this crucial policy. We also need to strengthen care across the entire mental health continuum, making all types of providers more accessible, not just physicians. Marriage and family therapists and licensed clinical social workers are 2 examples of non-physician providers that could make a huge impact in people's lives and on their health. We must also better align coverage to meet needs. The Biden administration recently released a report showing that despite long-standing mental health parity requirements, insurance plans inadequately cover all mental health care. Patients deserve better. Accordingly, today we will also discuss how we can strengthen our enforcement measures. The outpouring of interest in today's hearing demonstrates the urgent need for action. This hearing is just the first in a series of the topics which clearly are on the minds of the American family. I'm again pleased that Ranking Member Brady shares my interest and commitment to addressing these matters together. Ultimately, our goal is to take action as soon as possible and begin changing the way that we deliver and access mental health services in this country. We must eliminate the stigma around mental health care and focus on building a system that is holistic, accessible, and equitable. With that, let me recognize Ranking Member Brady for the purpose of an opening statement.
Thank you, Mr. Chairman. Thank you to our witnesses for being here today, and I agree that I think there is an opportunity for bipartisan work together on mental health and look forward to achieving that. I worry, though, that President Biden's administration has bungled the pandemic, including diverting funding from fighting COVID, damaging our economy and the population's mental health, and delaying vital reforms that would make access to telehealth permanent. Tragically, less than a dime of every dollar in the Democrats' $2 trillion so-called COVID stimulus last year went to COVID vaccines and defeating the virus. In the fallout of President Biden's border crisis, the administration diverted $850 million meant to support the nation's COVID-19 testing capabilities, instead using the funds to house individuals who crossed into the country illegally. After the humiliating withdrawal from Afghanistan, the Biden administration again diverted $120 million from COVID and testing to helping Afghan refugees. And despite having plenty of opportunity to make telehealth access permanent, I worry this Congress and this White House has only delayed consideration. The cost of the administration's failure on COVID has been suffering. That of our seniors living in isolation, our veterans struggling with post-combat mental health, and of America's children. Half of all seniors reported that during the pandemic, they felt isolated, spending more time by themselves. Not only were they not connecting with people, they weren't out there doing the things that they enjoyed that helped their mental health. Seniors were more likely to use telehealth in order to access wellness programs. And a third of seniors use telehealth to connect with their providers. We should make this even easier permanently. Veterans struggling with mental health issues have made ample use of telehealth. Last year, between January and January, the number of VA telehealth appointments increased 18-fold. But it's also so important to think of how we can help our kids. Much of what makes a rich social environment for our children has been replaced with crippling isolation. New research focused on New York City's youth found the visits to emergency rooms for suicidal ideation, suicide attempts, or self-harm in the last spring were twice as high as the previous year. Reuters reports that drug-related 911 calls for young people under the age of 20 increased by more than 40% last year, when many schools, youth sports, and other academic and social programs were closed in many states. Many schools and child care have still not returned to normal, which is only worsening learning loss and social isolation. Is it any wonder why the Surgeon General issued an advisory outlining the unprecedented impact the pandemic has had on the mental health of America's youth and families? President Biden, Democrats in Congress, I am frustrated with because they failed to address this in the $2 trillion so-called COVID relief package. It's frustrating that many agencies have hundreds of millions of dollars in unspent COVID funds. For example, recently the Department of Health and Human Services released data that showed 20 states and territories reported they haven't been even able to spend half of the COVID child care funding. 13 states and territories reported they've used none of the funds for child care. Families would benefit. These dollars were used as intended, or better yet, repurposed to address the current mental health crisis. Kids in need are suffering from mental illness. Child welfare workers are under greater pressure from the pandemic, and on any given day, there are nearly 424,000 children in foster care in the United States. Let's work together, as we have in the past, in good faith and a bipartisan basis to support our foster youth. That's one place, maybe the first place we can work together. Second, we can work together to fight the rise of opioid use and other forms of substance abuse resulting from the pandemic and an open borders policy. Republicans' majorities in the House and Senate led a historic investment in combating the opioid crisis, reducing substance use disorder in the country by enacting the SUPPORT Act. This bill put in place many common sense measures to reduce the unnecessary prescription of opioids and also to help those who become addicted. But we're losing momentum, both because of the pandemic and the influx of illegal drugs resulting from the president's border crisis. Between April and April of last year, there were an estimated 100,000 drug overdose deaths in the U.S., an increase of nearly 30%. Last year, U.S. Customs and Border Protection seized more than 10,000 pounds of fentanyl at the southern border, double the amount the year before. It's just critical, and that fentanyl is killing Americans, our neighbors, in our communities. It's critical we build on support, improve the Support Act together and access new challenges in combating opioids, fentanyl, and other forms of substance abuse. And finally, the committee can and should work together to make telehealth access permanent. This is the silver lining of the COVID pandemic. In the first year of the pandemic, the national weekly average of telehealth users jumped from 13,000 to 1.7 million. We need to make these telehealth access permanent. We've seen it work. It's saved countless lives of seniors and those facing dire mental health challenges. It's time to make this solution a permanent one. And I'll close here. On the heels of a raging pandemic and a terrible recession, we know the mental health crisis is real. I believe we have an opportunity together to fight it, the tools to fight it, and if we take a bipartisan approach in doing so, I'm confident we can achieve that. With that, Mr. Chairman, I yield the balance.
Thank you, Mr. Brady. Without objection, all members' opening statements will be made part of the record. So I want to thank our witnesses for taking the time to appear before us today, and I am pleased to welcome these very fine, impressive women to discuss this important issue. Let me turn to Congressman Larson to briefly introduce our first witness.
Thank you, Mr. Chairman. It is an honor for me to introduce Dr. Wisdom Powell, who is Director of Health Disparities Institute and Associate Professor of Psychology at the University of Connecticut. In her role as director, she builds academic and private sector community partnerships which advance the Health Disparities Institute's legislative mandate to increase health equity among Connecticut's medically underserved. She is extraordinarily well published, and she has previously served as chair of the American Psychological Association's work group on health disparities in boys and men. Dr. Powell, it's an honor to have you with us. Welcome.
Thank you so much, Chairman, and also to other members, Congressman Larson and other members of the committee. I'm really honored today to testify about America's mental health crisis. As a trained clinical psychologist and population health scientist, I'm bearing witness to this crisis in my day-to-day work. But like many Americans, this crisis has also found its way to my family's doorsteps. My 14-year-old niece is agentic, savantishly brilliant, but in the developmental throes of adolescence. And I'll be using the pseudonym Tasha when referring to her today. Tasha also has a history of mental health challenges that sometimes can overshadow her grit. And when she is thriving, she lights up a room. However, when she's having emotional struggles, she's defiant and self-destructive. And one evening, roughly 6 months ago, I received a frantic call from my sister telling me that Tasha was having a violent emotional episode. And we, as a resourceful family, launched into problem-solving mode. We attempted to locate a crisis center or other emergency psychiatric support services. I called colleagues to see if they could make a personal referral. None of these efforts produced a solution. The only option we had for rapid mental health support for my 14-year-old niece in 2021, during a period of intense tension between law enforcement and communities of color, was to call a police officer to the scene. There were no adequate systems in place for her, and despite the compassion and warmth of the arriving officer, he had limited formal mental health training and interpreted her symptoms through a law and order lens, because that's what his training taught him to do. So I'm here today also because we are failing Tasha and so many other children like her who have significant promise to contribute to our nation's economic vitality and competitiveness. My niece's story illustrates 4 key points about America's mental health crisis that I would like to use the balance of my testimony to highlight. The first point is that a shadow mental health pandemic is raging in our nation, and youth are most certainly at the epicenter. To be certain, we are observing pandemic period elevations in mental health symptoms like feelings of isolation, but also in clinical conditions like PTSD, generalized anxiety, and depression, a leading cause in worldwide disability. Depression is also a major risk factor for suicide, so the economic costs of our mental health crisis pale in comparison to the socio-emotional cost to our families and communities when our loved ones see suicide as the only way to end their interior suffering. The recent high-profile suicides of MARTA CEO and General Manager Jeffrey Parker, Hyattsville, Maryland Mayor Kevin Ward, actress Regina King's son, Ian Alexander Jr., and former Miss USA Chesley Christ are just a few tragic reminders that suicide knows no demographic boundaries. But if we think these data on the mental health crisis in adult populations are alarming, then we should all be kept awake at night by the state of mental health among American youth, because it's apparent from national data that more than a year lockdowns and remote schooling and the disruption of social norms have created growing levels of depression, stress, and anxiety and suicidal behavior among our youth. We're also learning that from national data that youth experiencing COVID-19 related events are even more vulnerable to mental health challenges and conditions. And if we are to be what our children truly need right now, then we have to fight for them as if our lives and future are at stake, because they most certainly are. The second point is that our current mental health labor force is inadequately supplied to effectively serve our nation's evolving demographics. On the night my niece Tasha had her mental health emergency, we learned a tough lesson about our nation's inadequate mental health labor force supply chain. And looking ahead and anticipating our future supply and demand is critical to ensuring our nation's readiness. Most projections suggest a decrease in the number of adult psychiatrists by 2030 and an overall increase in the supply of other workers across the mental health ecosystem. And in many of those models were simulated and analyzed before COVID-19. And if we could even accept these estimates as accurate projections, they still would significantly underestimate labor force supply chain inputs and outputs for historically excluded subpopulations, because the percentage of psychologists in the US workforce from these populations does not mirror their percentage in our nation. So if we're going to address this issue, we need to renew federal commitments to fueling and retaining a diverse, equitable, and inclusive pipeline to mental health careers, and training all mental health practitioners in culturally affirming and centered treatment delivery. My third key point is that mental health delivery systems are outdated, fragmented, and need to be radically reimagined to meet present and future demand. Because when faced with an outdated and fragmented health system, families and individuals have to make tough and unsatisfying choices about where to seek health care. Yet the fragmentation we navigate contemporarily is just a historical artifact of our US mental health care delivery systems. Our ways of organizing medical care into the treatment of the body as disparate organ parts also limits our radical imagination for system transformation, including aligning incentives for treatment of the whole patient. Pathways into the mental health delivery system are also very obscure for far too many Americans who, when compared to our nations, or other nations rather, are the most open to the receipt of mental health services. Limited psychiatric beds in our nation for adults and youth means also that many patients are boarding in ERs for extended periods, and this practice of boarding reduces the overall capacities of ERs to serve other patients. It also can diminish patient care-seeking motivations, because waiting in these settings can be extraordinarily long. And while telemedicine is not a magic bullet for systems transformation, its expansion has increased the uptick of services. And we have to ensure that these promising expansions don't hang in the balance as we wait to learn of their impact in the post-pandemic period. We also have to be very clear, and my final point is that unmet mental health needs will further exacerbate longstanding racial and ethnic health disparities and inequities. With every US population, we're seeing the weight of the mental health crisis. But historically excluded children with promise, like my niece Tasha and other adults with pre-existing mental health challenges, have the greatest unmet needs. In our nation, there's a long-standing and documented history of unequal treatment of Black, Indigenous, and people of color by healthcare workers. And those of us who work in partnership with these medically underserved communities know that it is not enough to reduce mental health disparities, but what we should be focusing on is creating mental or behavioral health equity, or the circumstance where every American has a fair and just opportunity to live his or her healthiest lives. In closing, I want to underscore that neither our emergent adult nor youth mental health crisis in America are a consequence of individual failings. My niece Tasha is not doing anything to deserve the mental health card she was dealt. She is simply an American girl daring greatly at becoming during a period of great social uncertainty. Youth and adults across our nation who are suffering in silence are also not doing anything to deserve the mental health cards they were dealt. America's mental health crisis is a wicked problem that has roots in structural disadvantage, environmental adversities, and barriers to high quality care. Thus, the solutions we offer should address these root causes head on and as an integrated component of mental health care delivery. Americans deserve better mental health care coordination, integrated delivery systems, and policies to not simply help them cope with mental health challenges, but to radically heal, grow, and thrive in their aftermath. This is my hope and prayer for my niece Tasha and every citizen, and I'm optimistic that there is a political will and a legislative way to do so. Thank you again for this opportunity.
Thank you, Dr. Powell. Let me introduce the witnesses now that we will hear from. Next is going to be Dr. Peggy Johnson, the Chief of Psychiatry at Commonwealth Care Alliance. Angela Saucer is the Executive Director of the Public Children's Services Association of Ohio. Next, Deborah Steinberg, a health policy attorney at the Legal Action Center. And finally, we have Deepa Avula, Director of the Division of Mental Health, Development Disabilities, and Substance Abuse Services of the North Carolina Department of Health and Human Services. Each of your statements will be made part of the record in their entirety. I would ask you to summarize your testimony in 5 minutes or less, and to help with that, there is a clock that you can keep an eye on that will be pinned to the screen. So with that, let me proceed by asking Dr. Johnson for her testimony.
Chairman Neal, Ranking Member Brady, and members of the committee, thank you for inviting me to participate in today's hearing. My name is Dr. Peggy Johnson. For the past 7 years, I've served as the Vice President and Chief of Psychiatry at Commonwealth Care Alliance, aka CCA, which is headquartered in Massachusetts. My 30-year career has focused on serving patients with mental health conditions and substance use disorder. Established in 2003, CCA operates a fully integrated not-for-profit healthcare organization dedicated to improving care for individuals with the most complex of needs. We provide our members patient-centered care across the continuum, including full integration of primary care, behavioral health, long-term care, and social needs as both a payer and a provider of services. As it relates to behavioral health care, we know that the integrated care approach makes a significant difference in ensuring patients with mental health illness that they have access to the range of needed services and support.
It's fantastic. No, thank you so much.
Currently serves more than 64,000 members in 4 states, with our largest health plans located in Massachusetts. Our organization is dedicated to serving those who are newly eligible for both Medicare and Medicaid. More than 2/3 of our members have a physical and/or behavioral health disability, and nearly 70% of those are diagnosed with a serious and persistent mental illness. In our One Care program, which serves duals under the age of 65, nearly 32% have substance use disorder and 7% are homeless. To serve these individuals, CCA uses an individualized approach with 3 major pillars. The first pillar is assessment. Upon joining CCA, all members are assessed by a specially trained nurse for their medical, behavioral, and social needs. CCA meets with these individuals wherever they may be it their home, a friend's house, a provider's office, or even a public venue, such as a coffee shop. The initial work results in developing a care plan tailored to addressing the patient's mental health and related needs. The second pillar is ensuring access to care, which is obviously a major concern. Once the care plan is developed, CCA's key focus is ensuring the individual has access to a broad continuum of care. CCA care partners and community health workers play a critical role in ensuring individuals have access to behavioral health care services, as well as support for medical needs. And finally, CCA also works to address social determinants that make it difficult for patients to access care, including vital services such as housing, nutrition support, and transportation. The third pillar is ensuring high quality and appropriate care. CCA uses a variety of tools and programs to provide quality treatment options to our members. In the area of substance abuse in particular, we know the opioid epidemic has been exacerbated by COVID-19, as has been mentioned. We are committed to addressing this crisis through safe and evidence-based intervention, including but not limited to the expansion of medication for opiate use disorder. Also, we are committed to utilizing recovery coaches who, through lived experiences, can help to implement a holistic integration of services across the continuum. In addition, CCA is fortunate to have crisis stabilization units. These units were developed as an alternative to the hard to come by inpatient care. We have learned through this intervention that members have had increased access to care as well as proven to be cost effective. CCA embraces the notion of all hands on deck in general, but it's certainly been implemented during this pandemic. CCA has proactively reached out to many of its patients and members by using telemedicine as a primary means of being in contact with them and assessing their wellness status. CCA's model of blending Medicare and Medicaid capitations combined with our team of dedicated in-house specialists, partnering with a robust network committed to serving complex individuals, allow us to provide effective and high-quality service to the patients we serve, including those with mental health conditions. Thank you again for this opportunity, and I look forward to answering any of your questions.
Thank you, Dr. Johnson. Ms. Saucer, would you please proceed?
Chairman Neal, Ranking Member Brady, and distinguished members of the committee, thank you for the opportunity to testify. I especially want to thank Chairman Davis and Ranking Member Walowski of the Subcommittee on Worker and Family Support for your efforts to improve the county human services workforce, and thank Representative Winstrup for your great work on this committee on behalf of Ohio. My name is Angela Saucer, and I'm the Executive Director of the Public Children's Services Association of Ohio, which represents Ohio's 88 county public children's services agencies. I am testifying on behalf of the National Association of Counties and its affiliate, the National Association of County Human Services Administrators. While specific county responsibilities vary from state to state, we deliver essential human services programs to support and stabilize families and play a key role in preventing and responding to child abuse and neglect across the country. In 11 states, including Ohio, the jurisdiction of child welfare falls fully or partially to counties. At their core, child welfare staff are first responders. Every day, they knock on doors to respond to reports of child abuse and neglect, not knowing what is on the other side. Caseworkers make critical decisions daily, often working for low to average pay and very little recognition. Turnover has been a decades-long concern in our county child welfare agencies, especially as child protection systems across the country have struggled with the rising number of children coming into care, in large part due to the opioid epidemic. Unfortunately, the COVID-19 pandemic has exacerbated existing mental health challenges for this frontline workforce. They are experiencing secondary trauma on top of higher caseloads as their coworkers burn out and leave for other jobs at higher wages and less stress. A recent national study of a representative subset of Ohio counties revealed that 53% of child protection caseworkers demonstrated levels of secondary traumatic stress that met the threshold for post-traumatic stress disorder. The stress on our workforce is directly connected to the mental health crisis affecting the children and families we serve. Even though state and federal laws governing children's services aim to protect children from abuse and neglect, nationwide there has been an increase of children coming into foster care whose needs are primarily related to mental health, developmental disabilities, or juvenile delinquencies. For Ohio, this represents 24% of children in foster care. County Children's Services agencies in Ohio and across the nation are struggling to find timely, safe, appropriate placements to address the complex, high acuity needs of these children. In a study my organization released today, found that 41% of caseworkers are calling 51 to 100 providers to find placements for children with high acuity needs. This negatively impacts the well-being of our already stressed and overburdened workforce. Recognizing that staff turnover and burnout place vulnerable children at greater risk for maltreatment, impede timely intervention, and delay permanency, county governments of all sizes and varying resource levels are feverishly working to implement solutions that can support the well-being of our human services workforce. As evidenced by the examples in my written testimony, this includes hiring clinicians who are available for crisis intervention, convening peer support groups focused on secondary trauma, making employee assistance programs more widely available, investing in high-quality trauma-informed supervision, and using ARPA for staff bonuses and pay raises with the goal of filling shortages, boosting retention, and keeping caseloads manageable. However, the severity of the mental health crisis merits additional support from our federal partners in the form of increased resources and programmatic flexibilities. With that in mind, we urge the committee to provide additional flexibility and guidance in Title 4E foster care administrative funding so that human services professionals can draw down federal dollars to provide mental health supports to staff. And we encourage Congress and the administration to develop a grant program supporting human services workers similar to the Health Resources and Services Administration's recent $103 million initiative for healthcare workers. We also urge an enhanced federal match to provide technological supports to frontline human services staff. And finally, we call for increased federal investments in the future human services workforce and a stronger system of care for children. Thank you for the opportunity to testify today and your partnership on this issue. I look forward to any questions.
Thank you, Ms. Seltzer. Ms. Steinberg, would you please proceed?
Thank you, Chairman Neal, Ranking Member Brady, and the whole committee for your leadership and the opportunity to testify on needed reforms to improve access to substance use disorder and mental health treatment in Medicare and private insurance. My name is Deborah Steinberg. I'm a health policy attorney at the Legal Action Center, a nonprofit organization that uses legal and policy strategies to fight discrimination, build health equity, and restore opportunities for people with substance use disorders, arrest and conviction records, and HIV/AIDS. Congress and CMS have made important progress to improve access to substance use disorder treatment for Medicare beneficiaries, such as through coverage of opioid treatment programs that Chairman Neal sponsored. Tragically, most Medicare beneficiaries, particularly older adults, still have no access to the substance use disorder treatment and lose access to insurance-based care when they become eligible for Medicare because of Medicare's treatment gaps and lack of parity. In 2020, approximately 3.4 million adults ages 65 and over had a substance use disorder, and less than 10% of them received treatment that year. Only 16% of the 1 million Medicare beneficiaries with an opioid use disorder received medications for their condition, and only half of those received counseling, all at a time when over 100,000 Americans died from overdoses. This is a systemic failure of our healthcare financing and delivery system that has long disproportionately burdened Black and Indigenous communities and results in incarceration for far too many individuals. Medicare coverage gaps not only shift costs to individuals and other financing systems, but they impose significant costs in Medicare as untreated substance use disorder exacerbates almost every other health condition. Medicare's coverage gaps include evidence-based services, practitioners, and settings. Substance use disorders are treated on a continuum, but Medicare only covers the bookends of that continuum, the least and most intensive levels of treatment, office-based and hospital care. Medicare does not cover the evidence-based intermediate levels of care, intensive outpatient, partial hospitalization, and residential treatment. As a result, many beneficiaries receive inadequate, if any, treatment until their conditions become acute enough to require costly and preventable hospitalizations, and they have nowhere to safely discharge because step-down services are not available. This coverage is in stark contrast to that for other medical conditions. Medicare does not cover the full range of diverse healthcare practitioners or community-based settings that offer substance use disorder treatment, including licensed professional counselors, licensed and certified addiction counselors, and peer support specialists. Apart from OTPs, community-based substance use disorder treatment facilities are not covered. Accordingly, even for the services Medicare currently does cover, beneficiaries cannot access treatment in a timely manner or reasonable distance. Finally, Medicare is not subject to the Mental Health Parity and Addiction Equity Act, the non-discrimination law that requires Medicaid and private health plans to offer mental health and substance use disorder benefits in a comparable way to medical and surgical benefits. Substance use disorder treatment is not only more limited, but the available services are also unequal to the scope and availability of services for other medical conditions. While Medicare is often the standard setter for other healthcare financing systems, it is strikingly more limited than Medicaid and private insurance coverage, which cover these services, settings, and providers and do so at parity. People lose access to their treatment and trusted providers when they turn 65 or become eligible for Medicare due to disability. We heard from one therapist who was asked every week by her client, "Do I still have to transition to Medicare? I don't want to lose all of my support." Individuals and families with other health insurance are also struggling to get the behavioral health care they need. Data show that people with private insurance are 5 times more likely to go out of network for mental health and substance use disorder care than for medical care, and out of network utilization is far greater for substance use disorder services. Although most individuals and families cannot afford non-network behavioral health care, the availability of those services demonstrates that workforce shortages are not the sole cause of limited behavioral health provider networks. As demonstrated by the most recent annual report to Congress on Parity Act enforcement, discriminatory standards in network admission, reimbursement rate setting, and network credentialing likely contribute to these network deficiencies. Congress can improve access to affordable care in QHPs and employer-sponsored plans by adopting strong quantitative metrics and enforcement standards for network adequacy. To fully understand and address the deficiencies in carrier networks, Congress should build on what it has already done in other contexts and impose additional data collection requirements to report substance use and mental health provider networks and plan improvement requirements for inadequate networks. It should protect consumers from balanced billing for non-network behavioral health services when networks are inadequate, as in the No Surprises Act. And it should authorize civil and monetary penalties against plans that violate the Parity Act as requested by the Department of Labor. Medicare reform will help root out discriminatory practices that contribute to limited provider networks and private insurance. Individual and group health plans often rely on Medicare Advantage as a starting point for network adequacy standards, and reimbursement rates are often pegged to Medicare rates. Since Medicare standards are not inclusive of many substance use disorder providers and are not subject to Parity Act requirements, discriminatory standards may be embedded in private health plans. We recommend Congress fill in these gaps in Medicare coverage to make treatment comprehensive and equitable, so we can not only help millions of Medicare beneficiaries, but we can improve access to substance use disorder and mental health treatment for as many Americans as we can across our healthcare systems. Thank you, and I look forward to your questions.
Thank you, Attorney Steinberg. Let me now recognize Ms. Avula for her testimony.
Thank you very much, Chairman Neal and Ranking Member Brady and members of the committee for the opportunity to testify today. I'm pleased to be able to share my perspective gained from my time at the Substance Abuse and Mental Health Services Administration on the national level, and also my current role as the Director for the Division of Mental Health, Developmental Disabilities, and Substance Abuse Services in North Carolina, led by Secretary Kinsley. We are indeed in a behavioral health crisis. I think we've all heard very compelling data on that. The truth of the matter is the crisis did not start today. It didn't start with COVID. When we look at data pre-pandemic, we know that there are staggering numbers of unmet treatment need in this country, with over 90% of people who meet criteria for a substance use disorder not getting treatment, and over half of the people who meet criteria for a mental illness not getting any treatment. We also know that from 2009 to 2019, high school students reported significant increases in feelings of loneliness and sadness at a rate of 40%, in thoughts of attempting suicide at a rate of 36%, and in actually creating plans to do so at a rate of 44%. Again, all of that was pre-pandemic. And then COVID hit. And we know COVID brought with it enormous stressors. employment instability, financial instability, grief, loneliness, isolation, all of these things contribute very heavily to an individual's mental health status. And the data bore that out, with 40% of adults reporting symptoms of mental illness. We saw that there were increases in pediatric ED visits for mental health reasons at a rate of 24% for individuals 5 to 11. Again, individuals 5 to 11, an increase of ED visits for mental health reasons. For individuals 12 to 17, that increase was 31%. Again, we know some of the restrictions that were put on adolescents and children were simply too much for many of them to handle. We also see staggering rates of alcohol use. When we look at the retail sales of alcohol in many states, the increase was close to a 40% increase in retail sales. Again, that was during the time when restaurants were closed, bars were closed, where you drink socially, you weren't able to drink socially. Yet the increase was still as big as it was. So what that means is many individuals were consuming very heavy rates of alcohol at home and often by themselves. When we also look at that data, when you compare it to with parental status, we see an extremely alarming figure of, if you had a child, your drinks per day increase were 4 times that of individuals who did not have children. When you look at that compared to all of the things we know happen to children, and if their parents were drinking at those rates, it really highlights, one, the stressors that parents were under, and so the need to support them, to support families, but it also highlights the very significant need we have to focus on children. At the same time as all of this was happening, as the demand was significantly increasing, we saw a very concerning trend in supply, with revenue loss, with program closure, with staff turnover. The National Council on Behavioral Health reported that 65% of organizations said they had to turn away, cancel, or reschedule appointments. We also know that on average, there was a 23% revenue loss reported in the past 3 months preceding the survey. All of those workforce challenges still exist today. They are definitely plaguing the system. They're making it very difficult to find adequate care and treatment. So we know the prevalence today of these conditions is extremely high. 53 million Americans live with a mental illness, 41 million Americans live with a substance use disorder. And again, on top of a system that is very much struggling with workforce challenges. So the reality is grim. But I do think that we should also focus on the fact that there are tools, that we know that there are effective and evidence-based strategies that do work. I'm going to mention just a few of them. I believe very strongly we have to focus on children's mental health. There are very effective school-based mental health models in order to do that, such as the Project Advancing Wellness and Resiliency in Education program. We know, as we've heard numerous times here, if we do not beef up our community-based services and our crisis services, we will be in a lot of trouble with the implementation of 988 soon around the corner. Again, the 3-digit number to reach a suicide lifeline. Unless we have places for people to go, that promise of that number will not realize itself. We cannot keep relying on EDs to treat our individuals with serious mental illness, mental disorders, and substance use disorders. We also have to double down on our efforts to treat substance use disorders, increase access to medication-assisted treatment, increase prevention strategies, and really focus on integrated models of care, such as the Certified Community Behavioral Health Clinic model. I feel strongly that we need to really take advantage of the flexibility offered via telehealth. I think truly telehealth saved our system, and it would be hard to go back. I think we really need to make some of these flexibilities permanent and take a look at what might happen if we don't. I truly believe if in the behavioral health field, we are at a very unique moment in time. And I think all of us need to recognize it is a sad moment, but it's a moment of great opportunity. And I think with collective action at the federal, state, and local levels, we can really improve the lives of millions of Americans. Thank you again for the opportunity to testify today.
Thank you. Dr. Powell, during my time as chairman, I have attempted to address the economic and health inequities that you made part of your testimony. What are some of the ways that you think we might overcome these challenges to ensure that everyone has access to care that is both structurally and culturally competent?
Thank you for the question. I think what's most important here is to recognize that what we're observing in terms of the fragmentation and limited opportunities for access are rooted in structural issues that happen outside the health system. We often talk about shoring up the resources and access to resources in the social and lived environment. Largely, mental health challenges arise out of a number of things: biological factors, the interaction of those factors with environmental adversities, but also from the lack of employment and underemployment, the lack of access to opportunities for upward social mobility, and more importantly, the interactions often between individuals and systems that result in mass incarceration. And unfortunately, in those settings, individuals are getting very limited health care or mental health treatment. And so they enter those systems broken and they return from them broken. So I think that we have to first address those issues that exist outside the health system. And then in terms of culturally affirming care, one of the things I want to note is that it's not enough to just have that burden of treating those with unmet needs rest on the shoulders of those who share the same social identities. Everyone has to ready themselves because we're in one of our nation's most significant demographic transitions. So we have to build systems and supports that mirror the population and train those people appropriately. That means integrating the training, not just in the periphery of curriculums, but at the center of them, and ensuring that everyone has access to that training and that people are held accountable to the training that they receive through incentives that are built into the way that we pay for high quality care.
Thank you. Dr. Johnson, thank you for your testimony. I'm really proud of the work that you outlined at the Commonwealth Care Alliance and your efforts to address mental health needs of residents who are duly eligible for Medicare and Medicaid. This is one of the most complicated issues that I've witnessed during my time in Congress. So I'm pleased that you have developed a model to attempt to address the integration of those two programs to the benefit of not only your clients, but to the country. So could you talk a little bit about what you did and the model you developed for a fully integrated approach?
Oh my goodness, would that I could take full responsibility for this. This is where CCA is now, is built on a history that began as an entity, but that provided primary care to very complicated individuals. Where we are now is based on an understanding of several things. One, we completely understand that individuals with complicated medical and psychiatric conditions with overlays of a number of social determinant issues require an approach to care that is significantly different than what one might consider the general population, if you would. So what we've done is several things. We have committed ourselves to serving those individuals, particularly those individuals with serious and persistent mental illness, in ways that are, one, flexible and innovative. Secondly, with an understanding that these are individuals who are particularly at high risk for death associated from medical conditions. And third, it has included implementation of services that are within our organization, but also maintaining high expectations of our network providers that are, in the language of today, accountable for the kinds of services that they provide our members as well. So it's been a tiered approach to improving the services that these individuals so obviously deserve and have been neglected in the past.
Thank you. Ms. Steinberg, you raised issues about improving gaps in coverage through Medicare and private insurance, and as you noted correctly, we have a long way to go. How would you suggest that Congress proceed with opioid treatment programs to expand the work that we did in 2018, as you noted, to ensure that all Medicare beneficiaries struggling with substance use disorders have access to providers and the services they need?
Thank you, Chairman Neal, and thank you for the question. It's exactly the right one. According to the Health and Human Services Office of Inspector General's report, about 40,000 Medicare beneficiaries received coverage from OTPs in the first year that the programs were authorized, but this is not nearly enough given the scope of the problem. However, what we do know is that these individuals received the behavioral therapy and the wraparound services that they needed, while those who were receiving treatment in office-based settings more frequently did not. So one of the barriers that we know is that GPs require people to come in person most, if not every day of the week. During the pandemic, it's not surprising that Medicare beneficiaries who were also at a heightened risk for COVID-19 did not seek out this new treatment option. And on top of that, we have heard from OTP providers that Medicare Advantage plans have made it difficult for them to join networks, even when they are treating patients with those plans and when there are insufficient numbers of OTPs in those plan networks to meet the needs of beneficiaries. And relatedly, although there are requirements for Medicare Advantage plans to report on their networks for certain provider types, this requirement has not yet expanded to OTPs, and we are still hearing from Medicare beneficiaries that they cannot find an OTP within a reasonable time and distance. So I think one of the things that is most important is making sure that reporting requirements for network adequacy include OTPs so we can make sure that they're actually available to beneficiaries who want them. And then also, thinking about the telehealth flexibilities that Ranking Member Brady mentioned, these are critical to helping folks access OTPs, especially given that they require such heightened need to go in person so many days a week, and that can impose additional transportation, childcare, so many other barriers. But it is also worth noting that although a growing number of Medicare beneficiaries are being diagnosed with opioid use disorders, the vast majority of Medicare beneficiaries with a substance use disorder have an alcohol use disorder. So when we're thinking about reauthorizing the Support Act, we need to comprehensively look at our substance use disorder treatment system in Medicare to ensure that we are actually meeting the needs of beneficiaries. Thank you.
Thank you, Attorney. Now let me recognize Mr. Brady, the ranking member, to inquire.
Thank you, Chairman Neal, and thank you to each of our witnesses. Director Avila, knowing what we know now, is there any justification for schools to be closed because of COVID? And I ask this because, last school year, Texas public and private schools remained open when much of the nation was closed. The school leaders, parents, teachers, students all worked together. It was extremely safe, next to no transmission. And the reason it was important to families like mine is my youngest son was a senior and really struggled in remote learning. I think gained next to nothing from it. But boy, really blossoms when he's surrounded by his teachers, his FFA instructors, ROTC instructors, when he's around others. It just made a world of difference. And I get frustrated because of the schools that continue in many ways to lock down. So in your view, Ms. Avila, is there any justification at all for these schools to be closed right now?
In my view, no. I don't believe schools should be closed now. And I think when we look at COVID mitigation strategies, I think rightly we talk about looking at the data. And thankfully, if there was anything you can say that was positive about COVID, it is that thankfully this disease did not have a major impact on children. Obviously, there were children that were tragically lost to COVID. But when you look at the data on behavioral health conditions and their effect on children and youth, and we know what school closures do to exacerbate those, when you're looking at the data for children and you trying to protect, again, their health and wellness, I believe that schools should do everything they can in their power and in local jurisdictions to remain open. I think that is the best for students. Students' overall health.
Yeah, so you mentioned in your testimony a number of mental health support systems that are available in schools. So do these successfully translate to remote learning? Or if you keep kids sort of isolated out of school, are we cutting them off from these mental health services?
So one of the things that you are definitely cutting students off from is sort of the daily interaction with teachers, other school personnel, the somewhat informal interactions that you also have in school that aren't, that the remote learning doesn't lend themselves to. So we know in certain states, for example, there were significant decreases in the reporting of child abuse and neglect. In no way was that actually corresponding to an actual decrease in child abuse and neglect. It was because children weren't interacting with mandatory reporters in the same way. So I do think, I don't want to say that supports cannot be provided virtually. They can, but I think absolutely there is a detriment to not having these supports being provided on site and having students and teachers and again other school personnel, other trusted adults in children's lives that interact with regular. I also think that children with disabilities who really relied on school-based services, not just mental health services, but other services relied on the school system. Those services weren't necessarily provided in the same way. And if they could be done virtually, they didn't necessarily have the same benefit.
So before, final question will be about opioid and that abuse, but I want to be really clear. I agree with Chairman Neal. There's an opportunity here. We don't have a mental health system in America, but what we now know is with telehealth done right, we have a chance to really create some opportunities here for young people, for individuals, for veterans, or the elderly to really have access to affordable and high quality mental health. And I really think this is the silver lining we can focus on. But I want to thank you for all your work on the Support Act while you were at SAMHSA. I think we're really starting to see some positive strides in our national battle against opioids prior to COVID. So now as we're emerging from it, we're seeing record amounts of fentanyl coming across the board. I don't know anyone who hasn't lost someone or knows someone who lost a loved one to opioid abuse. So in your estimation, are we better off today in our battle with opioid abuse than we were in 2020?
Well, I think if we look at the data, it would suggest that we're not, right? Just based on some of the data that are coming on. I do think that we need to look at some of the efforts that are very well outlined in the Support Act and really do all we can to expand access to needed services, expand access to prevention, expand access to naloxone. I also really, to the point that was made by the previous witness, I think it's very, very important when we talk about substance use of any kind, we cannot have a one drug at a time strategy. We cannot just focus on opioids. I think we need to recognize that the nature of substance use is polysubstance use, and our funding sources, policies should be flexible enough to address those. I also think that we need to really have a good, strong, again, community-based recovery support services. One of the things that we recognize when we talk about substance use disorders or mental illness is there are so many other services that surround the individual, like employment, like housing, like social connectedness. All of those things are critically important to a strategy on opioid use.
Thank you, Director,
treatment.
and thank you, Chairman.
Thank you, Mr. Brady. Without objection, each member will now be recognized for 5 minutes to question our witnesses. In this hybrid setting, we will dispense with the Gibbons rule, and we will proceed in the order of seniority, switching between majority and minority members. Because our witnesses are all joining us virtually today, members are reminded to please clearly state the name of the witness to whom you are directing your question. With that, let me recognize Mr. Doggett to inquire.
Thank you, Mr. Chairman. Mental health issues are certainly important to my colleagues who serve with me on the Health Subcommittee. 2 years into this COVID-19 pandemic with no definitive end in sight, so many Americans are clearly experiencing anxiety, fatigue, and depression. And social isolation has, of course, only exacerbated pre-pandemic mental health challenges. This burden has been particularly profound for our health and human service workers, as we have heard from our witnesses. These are the frontline people that are working to protect our communities with immense personal sacrifice. These workers have faced unfathomable trauma day after day, with patients experiencing emergencies and the uptick in violent crimes and vulnerable communities being further disconnected from the supports that they need. The stress, the genuine anger and despair witnessing such trauma can be compounded by poor working conditions. Many of these responders have lacked adequate personal protective equipment. Some employers have demanded that workers come to work sick, and many have failed to provide paid family medical leave, and the work itself becomes increasingly difficult as caseloads increase without additional staff hiring. A survey that was conducted here in my hometown of Austin by the Austin Travis County EMS Association, ably led by Selena Shee, found that almost 80% of our first responders working there were experiencing mental health challenges such as PTSD, anxiety, and sleep loss. These workers need mental health care, but they also need essential protections to improve their working conditions, like increased pay for the extraordinary demands of their job. I think that the mental health of so many Americans would be improved by the Senate action in passing, even at least debating, but passing the House-approved bills raising the minimum wage, protecting labor rights, establishing paid family and medical leave, and setting more adequate nurse staffing standards. And OSHA could immediately make their emergency workplace standard for health workers permanent. And of course, it's clear to, I think, almost everyone that those who have refused to mask, who have refused to immunize, have worsened our situation, and they have been worsened by those public officials who fail to condemn this and who don't act to encourage these public safety measures. Senate action on our House-approved legislation to close the coverage gap in states like Texas, where up to 2 million of our citizens have been denied access to health care because of the refusal of Republican state governors to expand Medicaid, would also greatly assist in providing additional mental health services. Another policy that I think is important, and the ranking member just mentioned it, is telemedicine. At one Lone Star Circle of Care Community Health Center here in Austin, 48% of telehealth visits in the past month were for behavioral health services. Just an example, an older patient caring for an adult disabled son is able to get telehealth visits for her own depression and caregiver fatigue that she might otherwise have to forego. The Telehealth Expansion Act, which I recently introduced with strong bipartisan support from leaders in this committee, is one thing that can be done to help us avoid a telehealth cliff when the public health emergency ends. Our legislation creates a pathway to keep telehealth services available with recommendations for guardrails, dealing with fraud, but basically assuring an inclusive design, affordability, and patient choice. I think moving forward with a markup on this bipartisan bill is one constructive step that our committee can take to improve mental health access. Ms. Avula, can you elaborate a little on the importance that you noted in your written testimony of patients having the certainty of access to telemental health services and how telemedicine has improved access and continuity of care?
Yes, certainly. Thank you for the question. As I said earlier, I believe telehealth was really, truly what saved the behavioral health care delivery system. When we started early with the flexibility, behavioral health providers weren't sure how to do it. They are in a completely different place today. It has engaged people into treatment. It has decreased no-show rates. It has brought treatment to areas where physical barriers existed, so people couldn't get to care. It has really increased rates. What I will say is where plans have pulled back, there is evidence that people are disengaging. So if this flexibility is suddenly stopped, there will be a significant number of Americans that lose care.
Thank you so much, and thanks to all of our witnesses for their valuable testimony.
I thank the gentleman. Let me recognize the gentleman from Florida, Mr. Buchanan, to inquire.
Thank you, Mr. Chairman, and I want to thank all of our witnesses. Dr. Avula, I'd like to ask, 53 million Americans have some sort of mental illness, and it's probably even a bigger number than that. But I did want to focus, and you mentioned about how grim and many of the concerns, and it's got worse, but there's some opportunities. So I'm thinking about what can we do this year, and then what can we do ideally in the next Congress. And I'm going to take a couple of subsets. There's a lot of people that are impacted, but I see in our community because of COVID with children, I have 8 grandchildren of 8 and under. Our family, in a sense, has dealt with it, but beyond our family, I just see so many kids that are at risk that have the challenges. What more could we be doing for them now and in the near future? I think it's a huge challenge. I think there's a lot of concern out there with a lot of parents. I've seen a lot of my circumstances with foster care and the impact that they're having. They're not sure from day to day with parents in terms of schools, and we've got the bitter fights in our community with that. So the stress that's going on families, and I especially, my heart reaches out to children, 10 and under, or 18 and under. But what's your thoughts and ideas about what we can do ideally this year? Because I don't think we can continue to wait, and then the next Congress. What's your thoughts?
Sure. So as a family member, as a grandparent, I think it's really important for people to talk to their kids, to check in with their kids on their mental health status. Also, I think as public health officials, we have to recognize that children are hearing us. Children listen to what we say, and we have to be careful to not induce too much fear and anxiety. And if we do, we need to talk to them about that. I also think
you did a great job with them, Afton. Thank you
as
for
legislators, I
proceeding
think
with
we're-
Some of the others, would members please mute themselves so that we might hear from the witness? Would you proceed, please?
I think there's a unique opportunity to invest in additional school-based mental health services. Again, I think it's really important that we really flood the schools with as much mental health care as possible. When I served on the Federal Commission on School Safety, again, prior to the pandemic, every school system that we visited across the country, that was uniformly the request is that we need more mental health care in the school, or more linkages to care. I think we can train teachers on things like mental health first aid to recognize the signs and symptoms. I also think there needs to be investment in the mental health block grant that has a set aside now for first episode psychosis. I think that set aside has been extremely helpful. Any type of intervention early is of extreme value. And I really, again, cannot stress enough the importance of an enhanced community mental health system and crisis services, because otherwise these children will sit in EDs, and that is not the right place for them if they develop severe mental illness.
Let me ask you also, I represent 80,000 veterans in our community, and the suicide rate, as you know, in terms of veterans is about 50% or 100% higher, depends on who you talk to. But it's been a huge concern. It's a bigger concern now more than ever. What's your thoughts of what we could be doing more this year? Because I think it needs to be more immediate, as well as the new Congress.
Sure. So I think on veterans programs, my state in North Carolina has done a great job addressing veteran suicide. And one of the major things it has done is really partnered across different systems to ensure that Veterans Affairs is connected with the Division of Mental Health and Health and Human Services, and bringing together different collaborative partners that I would very, very strongly encourage you also to require that veterans are part of the strategy. I believe strongly in the nothing about us without us concept, and I think that can be applied here. Veterans know what they need. I think we should ask them, and I think we should engage them in that conversation. I think also additional resources for suicide prevention efforts specifically geared to veterans. They have very specific issues that address their mental health in a very unique way, and I think we should really target resources to that population. I think targeted resources in that arena, things like the Governor's Challenge, the Mayor's Challenge, where states and cities were asked to develop comprehensive strategies for addressing veterans suicide. And those strategies worked. When you bring local people together and you give them all a task and require them to do certain things, they will do it. And it does take funding. So those are the things that I would say can be immediately done.
Thank you, and I yield back.
Thank the gentleman. Let me recognize the gentleman from California, Mr. Thompson, to inquire.
Thank you, Mr. Chairman, and thank you to the panelists who have joined us today. Mental health is just the most important issue or threat that we are facing today. And I think you got the title right. This is, in fact, a health crisis. We see it everywhere in our schools, the homeless population in prisons, among our veterans, and among our seniors. We see it in a number of people overdosing each year, and we see it in the number of people who tragically take their own lives. COVID has made it all worse, not only by exposing gaps in our healthcare system that exacerbate mental health challenges, but also by requiring long periods of unusual isolation, by forcing people out of the workforce, by keeping children home from school, and by taking the lives of over 800,000 of our loved ones. As I said, this is a crisis, and one sorely needed, in need of congressional action. There are a lot of tools at our disposal, but I'd like to highlight a couple things that I'm working on that I think would address this issue. First, studies show that senior citizens suffer from substantial rates of mental illness, especially depression and anxiety. And one of the key problems here is a supply problem. We don't have enough mental health professionals to meet the demand. I've introduced bipartisan legislation, bicameral legislation, the Mental Health Access Improvement Act, which would expand the pool of mental health professionals available to seniors on Medicare. Dr. Steinberg, right now, Medicare beneficiaries can only access mental health care from a limited number of providers. My bill would expand that group to include licensed mental health counselors and marriage and family therapists. Can you talk a little bit about mental health challenges facing seniors and how they might benefit from accessing additional groups of counselors and therapists?
Thank you, Congressman Thompson, and that's a fantastic question. Yes, as you stated, more than a third of seniors display symptoms of depression in primary care settings, and we know that these individuals are not able to then access the mental health counseling and other services that they need because the provider types are not covered. Licensed professional counselors and marriage and family therapists in particular are already providing treatment in all 50 states where they are licensed and certified. And that means they're also providing treatment to people with other types of insurance like Medicaid and private insurance. Rural counties in particular suffer disproportionately from mental health shortages. 50% of rural counties have no practicing psychiatrists, psychologists, or social workers, which are the main mental health providers. So that means people do not have access to mental health treatment because Medicare is falling short of covering these other practitioner types. Together, marriage and family therapists and licensed mental health counselors in particular make up 40% of the mental health workforce. So their lack of coverage is severely limiting access to care for Medicare beneficiaries. So the bill you have sponsored is exactly the right sort of thing to help get older adults and other Medicare beneficiaries the treatment that they need. And it can be further expanded to cover addiction treatment providers as well to ensure that we are really treating the full scope of the behavioral health challenges that people are currently facing. So thank you for the question.
Thank you very much. A longstanding priority of mine has been telemedicine, and I'm proud that the expansion of telehealth in Medicare during COVID-19 was an inclusion of legislation that I had drafted. We've seen an explosion in the use. Everybody I talked to said it's fantastic. One of the witnesses, and Congressman Doggett, already talked about it. Dr. Johnson, can you talk about the utility of telehealth for mental health patients?
Yes. It has been the case that telemedicine was slow to be adopted by many mental health providers across the country. And as has been referenced, if not for COVID, perhaps we would still be a bit in that state. But because we needed to respond, and telemedicine did in fact, in my mind as well, save behavioral health. Its benefits are multiple, but the one that I would choose to focus on is the increased obvious access. One of the major problems that we are obviously all discussing is the significant problem with the number of behavioral health providers and where they happen to be primarily concentrated, which is largely in urban environments. I am one of those individuals who is originally from a rural area, small town East Texas, about 1,400 people, and it was my first experience with telemedicine and the understanding of the needs of the primary care clinicians and other service providers in terms of the absence of behavioral health care, with the exception of telemedicine that certainly implanted in me the need for this kind of service. We certainly understand that there are some individuals for whom this is not the optimal care, but in general, I think in consensus with most of the speakers on this committee, that it would be a travesty to not continue with the allowances that have been granted in this emergency situation, because I do think it would be a tremendous step backwards in terms of the access issue, which in my mind is one of the primary drivers of obviously the inadequacy of behavioral health care.
Thank you very much. I yield back.
I thank the gentleman. Let me recognize the gentleman from Nebraska, Mr. Smith, to inquire.
Thank you, Mr. Chairman. Certainly thank you to our panelists for this timely discussion. I think we as a country have come to appreciate perhaps various dynamics of community and so forth, and the interaction among various communities, colleagues even in settings like this here in this institution. I think when we look at mental health, certainly impacting my district, we had a natural disaster with a blizzard and flood right before COVID. We've had struggles in the agriculture economy that have impacted mental health in some very rural and remote areas. And so I appreciate the opportunity to work on some topics. Certainly the PEERS Act that Ms. Chu and I have been working on that allows for peer support in Medicare as one of the solutions that we are focusing on. Obviously, as has been mentioned, telehealth is important to all communities. I was working on telehealth before COVID when it was for purposes of rural care and access, and now telehealth is needed across our entire globe. Looking at education, I think it's important to note that in my interaction with students early on during the pandemic, some of the students appreciated the fact that they could work more independently. But that was early on, and things changed the longer that students were out of the classroom, and I think there's renewed appreciation for what classroom instruction can achieve and the accommodation of learning styles, realizing that so many students learn differently with different types of interaction, and I would hope that we could afford our students ultimately the flexibility that they need for that in-person learning and what they can achieve with that. Ms. Avula, I do have a question, and what you think are the most effective opportunities for us to use telehealth and new technologies to improve access to mental health care, especially in the rural and underserved areas.
Thank you for the question. I do think that telehealth can be used quite broadly. I think as we've seen, it has been used quite broadly. I think there was an earlier point about OTPs. We have seen for opioid use disorder treatment, telehealth in combination with some of the flexibilities around medication take home and things like that, particularly in rural areas, that will help quite a bit. I do think telehealth for other types of virtual support groups as well. Peer support groups have been done via telehealth. I also think that, or via kind of telephone or audiovisual services. I also think that intensive outpatient has also been quite successful. People were not sure if that was going to work, but it has. Again, kudos to the behavioral health field. They have really, in a very short period of time, the practitioners and providers have figured out a way to really transform what was a truly face-to-face delivery system to incorporate real technology and virtual platforms to really still simulate a great treatment experience for individuals. So I think telehealth can be used quite broadly. Okay. Particularly in rural areas.
You touched a little bit on audio. Do you think that audio-only options for mental health telehealth can be used to effectively expand the access and provide support in rural and underserved areas without creating too much vulnerability for fraud and abuse?
Yeah, thank you for that question. I think it's an important question. And when we were looking at flexibilities at SAMHSA, and we had put out something we thought would solve it, we had put out something about audiovisual the use of audiovisual, and we got calls right away from rural communities that said, this isn't going to help us. So, thank you, but it's not going to help. And I think we have to hear those calls. And I think we have to take that quite seriously and really look at audio only services. There are communities that can only do that level. And I think we have to respect that that's where certain communities in this country are. So I do think that we have to consider that. I was a former CFO. My job was to do audits and look at fraud and things like that. I think it's very important to put balance and make sure there are checks and balances in the system to look at fraud. But generally speaking, over these 2 years, in terms of the cost benefit, it seems like there is some real benefit to continuing that flexibility as well, again, with appropriate guardrails.
Very well. And thank you. I yield back.
Thank the gentleman. Let me recognize the gentleman from Connecticut, Mr. Larson, to inquire.
Thank you, Mr. Chairman, and thank you again for holding this important and critical hearing. I've found that whenever you doubt what's going on in America and you look at its future, travel to one of our schools. Last week I happened to go to Glastonbury High School in Connecticut in my district, and I ran into 3 extraordinary students who won the app challenge. Raul, Natish, and Jude, exceptional students, developed an app, and they chose for their theme mentality because they recognized that amongst their own peers, they were experiencing extraordinary stress because of the pandemic and also because of a lot of the concern that so many on this committee have already elaborated on with respect to fentanyl and the opioid crisis as well. It says a lot when you have high school students who recognize mental health and the epidemic and feel that there's a need for them to act. And they created an app, and I would like to enter for the record, Mr. Chairman, their application for the app challenge, because I think people will find this information incredible. St. Francis Hospital in Hartford, in conferring with them, says that there are as many as 200 adults and over 90 children seeking care for behavioral health just in emergency rooms in Connecticut. That's pretty remarkable. We need to act to address this crisis now. I have spoken to the Connecticut's Children's Hospital, which has really emphasized what we need to address with regard to mental health care for children is strong families, which help support the emotional health of kids. Like we did in this committee with the passage of the child tax credit, something spearheaded by our own Rosa DeLauro and Susan Delbene on this committee, and Mr. Chairman, with your leadership. Dr. Powell, in your testimony, you sounded the alarm on child health care crisis that our youth are facing. How does the childhood poverty and all of its implications compound mental health issues and the ability to get treatment, in your estimation?
Thank you for the question, Congressman. I think we have to recognize first that poverty does instigate poor mental health outcomes, but perhaps not by the pathways that we assume. One, children who live in impoverished communities are not hardwired for poor mental health outcomes. Rather, those children interface with systems and structures that fail to rise up to meet them at their highest intentions for radical healing. What our children in poverty often face are barriers in access to treatment and the availability of high quality care. They're often also forced with dealing with a mental health system that's fragmented and also extraordinarily high cost for those who may be or underinsured. And so if we were going to address the issues that many children who live in disadvantaged communities face, then we have to fix the structures and systems around them. And I know we keep saying this, but it is really important for us to underscore that no child deserves to be left behind in this way. In my opinion, there are many opportunities for us to facilitate better child mental health outcomes. And the first is one that we've already been discussing, and that is meeting children where they are, speaking to them and with them as opposed to over them. Children and youth have tremendous potential to contribute to our innovations, particularly in the digital health landscape, where we're seeing the sort of onboarding and emergence of new and effective digital mental health tools. Our children have tremendous tremendous opportunity to also help us reimagine the very systems that we say are supposed to serve them. In addition, we have to think about the settings where children are most likely to interface with mental health professionals and caring adults. As we've been discussing, schools are important, places and spaces for delivering mental health care, and yet those systems and spaces are woefully understaffed with appropriate care. We have to think about how do we use the staff that we already have available to us, because teachers are incredibly overburdened. We cannot train our way out of this crisis. Particularly, we can't teacher train our way out of this crisis. What about reimagining the roles of school resource officers, scrutinized in this era of discussions about the involvement of law enforcement? What if we provided them with more tools to provide mental health first aid? In the work that I do in countries outside the US, particularly in Kigali, Rwanda, where they have 2 psychiatrists, I think, in the entire country, they are utilizing the bandwidth and the ingenuity of lay health providers to support them in bridging and minding the gap. And we have to do that also. We have tremendous opportunity by deploying our community health workers, figuring out how to align payment and reimbursement systems to pay them and incentivize them, and integrating them fully into the mental health delivery system. We can do that in schools as well. The bottom line is that we owe it to our children to wrap our arms around them, to speak cumulatively to the wounds, collectively to the cumulative wounds that they are metabolizing in this moment. That is our duty, and that is what we must do if we're going to prepare our nation to compete globally in the future.
Thank you. I yield back.
Thank the gentleman. Let me recognize the gentleman from New York, Mr. Reed, to inquire.
Thank you, Mr. Chairman, and thank you to our panelists and witnesses for their input today. One of the things I wanted to explore, and I'm going to direct this question to Ms. Avula, if I could, is it's been brought to my attention as I've dug into this issue over the years that when we deal with mental health and substance abuse, there is a well-known silo effect where providers who are providing or patients that are diagnosed with a substance abuse situation don't have access or cannot qualify to be seen by a mental health provider because there's this silo between the two treating worlds that just doesn't coordinate with each other. That you have people that are in crisis, be it because of a mental health issue, and I'm not aware of many people that don't have a mental health issue that also don't have an addiction issue or a substance abuse issue or vice versa. But they don't have access to the right providers. So the one school of treatment providers doesn't work or doesn't cross over very well in regards to providing those wraparound services for both mental health and substance abuse needs of those patients. So first, I'm just going to ask you, Ms. Avula, is that an accurate summary of an issue that we are facing in this world that has been brought to my attention over the years? Yes or no?
Thank you so much for that question. Yes, accurate.
Yes. Why is that? Why have we created this system where people that are in crisis with be it an addiction problem or with a mental health problem or dual problems, why has that come into an existence, and how would you recommend Congress move forward in fixing that silo effect?
Yeah, so one of the reasons it's come into existence, I think, is just sort of how the fields have grown up. They have grown up pretty separate from each other, even though the co-occurrence issue is pretty strong and should be treated. Absolutely everything you're saying is 100% true, and we need to fix that. We need to have mental health professionals who are screening for substance use disorders and the opposite. There really should be sort of no wrong door on the behavioral health side. It shouldn't matter that you happen to go to a mental health professional. It shouldn't matter that you happen to go to someone who was trained in substance use disorders. I think we need to definitely, certain things can be done, like encouraging screening for both conditions, regardless of who you see first. I think when you look at federal appropriations, like for example, for the Substance Abuse and Mental Health Services Administration, the appropriation for mental health is separate from the appropriation for substance abuse treatment and substance abuse prevention, even though it's governed by the same agency. Those appropriations are separate. So separate laws and separate appropriations govern those things differently. I think one of the ways to address this, obviously, if appropriations can be combined, that's one thing, that's a longer term strategy. I think an immediate strategy, though, is previously SAMHSA did have programs specifically geared for co-occurring disorders. I think infusing some of those programs and really ensuring, again, a cross-training of the field. I think educational programs. So we started a program called the Substance Abuse Treatment Education Program, where we gave grants to schools to implement courses on substance use disorder treatment in mental health disciplines. That's not happening now, and it's not happening at a great rate. It should be, but it's not. So anything on pushing on that particular issue on the training side, as students are being trained in these conditions, would go a long way in providers understanding the issue of co-occurring disorders.
Well, I appreciate that. And one of the things that was also brought to my attention is just maybe one of the causes of this is just the coding issue that comes out of the reimbursement policies for Medicare and Medicaid. Because there's a financial disincentive in regards to trying to treat both or not being reimbursed for providing both. Is that an accurate understanding that the coding issue could be an issue that we need to address?
Yes.
And would you recommend that we go to CMS and the others that are involved in that process, try to work that coding problem out so that we do not disincentivize the wrong?
Yes, I think that. Yes, I think absolutely. I think the administrative issues on same day and other billing issues that affect this, again, the co-occurring issue exists in the world. Our policies should reflect the fact that it does exist.
I appreciate that. And with that, I yield back the balance of my time.
I thank the gentleman. Let me recognize the gentleman from Oregon, Mr. Blumenauer, to inquire.
Thank you, Mr. Chairman, and I appreciate having this hearing today. We all have been faced with amazing challenges at home that we're hearing. It underscores the good work that we've already had helping people keep their head above water. I think the work, Mr. Chairman, you, Mike Thompson, have done dealing with telehealth and expanding that is an example of something that is making a difference, where we're doing things that make sense, expanding resources, and hopefully is going to continue on into the future. Let me say I am deeply concerned about the battle against substance abuse and demographics that are underlining much of what we've heard here today. One area that I am particularly concerned, hearing about the forces of burnout in the workforce. Part of the challenges there are the turnover that we're seeing with providers. I saw one estimate where each person who leaves their job and needs to be replaced adds an extra $50,000 of extra costs. It suggests that our being able to make some investments dealing with this workforce stress, the problems on providers, will help us cut down the cost of the failure of the system. This would be money, I think, very well spent. I'm encouraged in the course of what we've heard from our witnesses and discussion with the committee members that there are a variety of areas here that we can hone in on. There's so much complexity, so much, I think, shared concern about the challenges, and it is broadly shared. And I'm hopeful that we can focus on a few of these things to reduce the cost of failure, like investing in the workforce itself, that will pay multiple benefits in terms of people who are stressed and being able to do their job better. And ultimately, I think it will save the taxpayer money. So I appreciate the conversation today, the witnesses, the interaction with the panel, and it gives me hope that there are things we can do together that are going to make a difference, because we're going to be in the middle of this for a year or two to come at a minimum. Thank you, and I yield back.
Thank the gentleman. Let me recognize the gentleman from Pennsylvania, Mr. Kelly, to inquire.
All right, thank the chairman, and thank the panel for being here with us today. When we look at all these problems, they all end up being some kind of a structural problem, it seems to me. I like Mr. Reed's line of questioning, and for all of our panelists, I think that almost anybody in any business today is saying the same thing. There's not enough talent to treat the market that's out there. We have more patients than we have doctors. We have more patients than we have physician assistants. We have more people who need help than we have people who can help them. And I think the gentleman from Oregon is right about how do we get people to go into this business? So having this experience, and for some of us, while we may not say it here, I think Ms. Powell brought in the story of her niece. We're all at some point touched with this situation. There's nobody that's walking free in America today that doesn't have somebody in their family, somebody in their extended family, somebody in their friendship that's not having these problems. And I just keep wondering, but the answer is always, well, Congress better do something. So I don't know where this thought process came out that somehow we have this magic wand that all we have to do is wave it and all of a sudden we get the money to the right places at the right time and the right amount, and we encourage people to go into a business that they never thought of before. And I'm talking now about health care, whether it's helping people with a physical problem or with a mental problem. And you know, with a mental problem, because it has such an effect on people, it's one of those things, there's no problems in my family, there's just a lot of things we don't talk about. And these people need help, but we can't get help to them. I think Mr. Reed said one of the things that happens is that if you have one of these problems, you probably have an addiction that goes with it. So, Ms. Avila, I was really fascinated by what you said, and I don't know that we can get a handle on this. The volume of what we need is just not there. And I think that if any of you can, and this is a question for all the people on the panel because you're all so relevant and you're all so spot on with it, even with prior authorization, people that have mental health problems, they can't move forward. They go to see a doctor, but all of a sudden, well, you don't have prior authorization for this, so you're going to have to go back home and wait. That's the one thing you don't want them to do. It's like telling people that come into an emergency room that are in a serious injury, well, we don't have prior authorization, we can't take care of you today. Just hopefully you get through this and we'll get to you sometime in the future. We have a bill called H.R. 3173, and I think these panels are really good because we get to feature things that we're working on, and then people back home say, oh, you know, they're doing their job. We do have to find a way to fund these things. Ms. Avila, just give us an idea, because the old saying is out there, you can't fix something with nothing. What is the something we need to fix this nothing that we don't have right now? We don't have enough providers. I get all that. We don't have enough people that can help. What is it you would suggest? Give us something to fix where the problem is, as opposed to saying Congress needs to get it fixed. What is it that you think we should do?
So I think there are a number of things that can be done, but I agree with you. It's not going to be fixed overnight, and it's certainly not going to be fixed by one action Congress takes. So I just want to say that up front. I do think, though, there's 70+ million Americans out there that depend on us to try to fix it. So I think we have to try to fix it. And I think one of the things we can do, you mentioned this, is talking about incentivizing people to go into these fields with things like loan repayment. The HRSA program, HRSA's programs have a lot of incentives to get people to go into this field. If we stop there, though, people will get into the field and then they'll leave. And we don't want that, right? So we also have to make sure that people are getting paid the wages commensurate with the work that they're doing. And really look to all levels of professionals that are in this, not just medical professionals. We need to look at the psychologists, the social workers, the counselors, the peers, the marriage and family therapists, and make sure that there are not administrative barriers to those individuals who are a big part of the system getting paid. I think that's another major thing we can do. The other thing I mentioned is the cross-training. The specialty field alone is not going to fix this. So we need to be training primary care providers and other healthcare providers. The Substance Abuse and Mental Health Services Administration has a large investment in technical and training assistance to do that. I think double, triple, quadruple that investment to make sure that individuals are getting trained. The other thing we can do is mainstream these training, have schools who are required to teach these types of things, because unless we take away the stigma on the front end, also, we have to be very mindful of that. There's a lot of stigma on the front end, which is also creating an issue for providers to treat these individuals. Again, not in the specialty field necessarily, but certainly in other fields. So we have to do, it's a multi-pronged approach.
Well, I appreciate you being here today, and all of you on the panel, because we're not looking at this as Republicans or Democrats or Libertarians or whatever people want to identify. That we're talking about Americans who represent their fellow Americans back home, and these are problems we have to get solved. And we can do it together if we could get the damn politics out of it. Thank you so much, Chairman. I yield back.
I thank the gentleman. Let me recognize the gentleman from Wisconsin, Mr. Kine, to inquire.
Well, thank you, Mr. Chairman. Let me first, again, thank you, Mr. Chairman, for teeing up this hearing. Such a critical subject, especially in light of a global pandemic and the social isolationism that has come from all that. And the real spike in the need for mental health services. And I want to thank all our witnesses for your excellent testimony here today. But a part of me is sitting here in great frustration. You know, I was involved heavily back in 2008 with the passage of the Mental Health Parity Act, as were many members of this committee, including our dear friend and former colleague Patrick Kennedy, who was on a personal mission to make sure we passed that crucial piece of legislation. But a lot of the gaps and the challenges and the lack of integrated care that existed back then, we're still talking about today. So in a way, it feels like we haven't made the type of progress that we were foreseeing back in 2008, and there's still so much work that has gone unfinished here. Well, let me bring this back to the unique challenges affecting my congressional district, large rural Western Wisconsin district, and the challenge we have in rural America as far as access to mental health services. And Dr. Powell, let me ask you, because I know you touched upon this briefly in your written testimony in regards to the challenges that we're facing, but in recent years, we've seen a huge spike in suicide rates with our farmers and ranchers, who are 3.5 more times to die by suicide than the general population. In Wisconsin, we've had 3 years of record family farm bankruptcy. You know, the isolationism that rural life brings, the stigma that it still holds in these communities are huge barriers to access. And it is a challenge. And I'm glad you did touch upon the advent of telehealth services now, especially what we've seen here with the pandemic and the need to continue it. But could you just speak a little bit in regards to what we have to be focused on and closing that gap in rural America when it comes to mental health services?
Thank you for this question, because as I listen to us talk about and bestow the benefits of telemedicine, I listen with great, interest and also support. I believe that telemedicine has really expanded the access highway and has made it possible for many people to get connected. But here's the rub. People who live in rural communities or in other disconnected community settings are also facing barriers to telemedicine because of issues related to broadband access. Many people who live in rural communities and who live in urban communities face issues around crowded housing, multi-generational housing, that makes it more difficult for them to even reap the benefits and rewards of telemedicine. We also know that for some populations where high stigma is present, having that personal in-face connection is critical to restoring and bridging trust gaps that have existed in some communities for a very long time. So I want to implore us to think about those issues as we consider what access entry points might be available. Now, here is something that I think is also important as we think about disenfranchised communities. We have to think about the fact that the Mental Health Parity and Addiction Equity Act, which was really important, produced a number of opportunities for us to level the playing field, but there's still a number of existing insurance and policy level loopholes that compromise patients' ability to secure affordable care. There are lifetime maximums also on the receipt of mental health care that mean many more patients leave treatment without having their mental health challenges remedied or mitigated. And there are also scores of uninsured patients in rural and urban areas unable to pay the high cost of mental health care, even when it is available. So we have to think about what are some of the ways that we can get into those interstitial spaces. And again, I harken back to us leveraging the full range of our citizenry to address these issues. There are things for which the top of the funnel providers have to do. Psychiatrists have to be the folks who prescribe medicine in our current system, because that requires a level of training that most professionals don't get. But we can utilize the full spectrum of our populace to do things like rapid mental health first aid, rapid assessments and referrals. And we also need systems that can speak to each other. So we need to solve the data interoperability challenges that are presented when we need school systems to talk to social services systems in ways that fully integrate.
If I may, I think it's such a crucial point. And again, you referenced this in your written testimony, but using the full panoply of the workforce that exists, including community health workers, and the need to adjust the payment schedule and the reimbursement schedule in accordance. So I think we need to be looking at alternative payment models. I mean, PhDs and MDs are important. We need to have them, but we need a much larger universe of providers out there, and that needs to be reflected in our reimbursement system too. And so I hope to work with the centers on innovation and look at some alternative payment models that will address some of the shortfalls that you described so well today. I appreciate that. Thank you. Thank you, Mr. Chairman.
I thank the
see my
gentleman,
time
and
has
I'm pleased
expired.
that the gentleman found the time to talk about the advances that we've attempted to make on the committee, but also highlighting the confusion that surrounded mental health parity. There was a former member of our committee here, Jim Ramstad, who had been very instrumental in bringing about that substantive achievement and debate, but the confusion over parity and how payments were rendered really plagued the system. And many people found themselves staring at bankruptcy because they didn't understand the limits of insurance opportunities and reimbursements at that time. So it's important to recognize Pat Kennedy and at the same time Jim Ramstad from this committee, who had experienced a series of challenges in his own life which propelled him in the direction that we all want to be desirable. With that, let me recognize the gentleman from Missouri, Mr. Smith, to inquire.
Thank you, Mr. Chairman. You know, it's fascinating that we're meeting here today about mental health and child care, and that several of our witnesses are bringing up workforce shortages. These shortages didn't just magically appear out of nowhere. The truth is the policies of President Biden and Washington Democrats have devastated our nation's workforce. And if we're not careful, we'll run our economy completely into the ground at a time when small businesses are trying to recover from the pandemic. Rampant federal spending has led to the highest inflation in 40 years. The cost for food, energy, and housing, it continues to rise at an alarming pace, and working families' income continues to decrease as their paychecks are stretched to cover new costs. And what is the answer for my friends and on the other side of the aisle to our lagging economy and record workforce shortages? Simple. The only answer they ever have: blindly throw more money at it. But what good is that money if families can't get what they need at the grocery store and are paying more than they ever have at the gas pump? It's a Band-Aid for the much larger problem of our nation's worker shortage, largely caused by the Democrats' failed fiscal policies and authoritarian vaccine mandates. Washington Democrats, they want the American people to be fully dependent on government, collecting checks to barely scrape by as costs rise all around them. Well, guess what? Working class Americans, they don't want their lives managed by a government bureaucrat. They don't want command and control over every facet of their life dictated by Washington. These same failed policies have contributed to the skyrocketing cost of childcare, pushing it in an unaffordable level, all while quality continues to decline. As our witnesses today have pointed out, the childcare industry also continues to suffer from workforce shortages. Mask mandates, isolation, and so-called hybrid learning environments in schools and childcare facilities continue to stunt the behavioral growth of our nation's children. I've asked the administration repeatedly to explain its anti-science stance on child masking, a stance more restrictive and draconian than any other nation. I have yet to receive a satisfactory answer as to why we are among only a handful of developed countries who require children as young as 2 years old to wear masks 8 hours a day. You want to talk about mental health? What happens when we find out that we have permanently harmed these children? Children learn appropriate behaviors in part by watching social cues and emotional reactions, and we're making it nearly impossible for them to do so when they're interacting with the outside world. What about the mental health challenges developing due to learning loss of students with routine disruptions in their classroom setting? Are kids feeling isolated because they don't get to interact normally with their friends at school due to ridiculous rules requiring students to stay apart from each other? Education in America has turned into a circus, with Joe Biden and the Democrat Party as the ringleaders. Ms. Avula, are mask mandates, isolation, and hybrid learning in schools damaging our children's mental health and increasing our children's rate of substance abuse?
As I have testified, I do believe that schools should be open for in-person learning. I think that is very critical to children's mental health and children's overall health, not just their mental health. I think we have to talk about that broadly in terms of children's health and wellness. I don't know, as you mentioned, the long-term data on masks aren't out yet because we're just starting that. So I can't speak to that, but I certainly can speak to the value of children being in person for their learning. And I think absolutely we should do whatever we can to ensure that schools across this country are open.
Thank you. I yield back.
Thank the gentleman. Let me recognize the gentleman from New Jersey, Mr. Pascrell, to inquire.
Thank you, Mr. Speaker. We could have a real debate and discussion after the gentleman from Missouri presented such a positive picture of Democrats addressing the issue of many health problems. And while I will respect your opinion and your right to obviously communicate it, we have offered some solutions on our side of the aisle, and we sure haven't, in the midst of the discussion, turned to adjournment so we wouldn't have to make a decision. Facts matter. I want to say to Dr. Powell, I think everybody on this committee, and I think everybody on this committee has the capacity of intellect and desire to make America better. Now, the government can't do everything. We agree. Everybody agrees with that. Because we do not want that type of government. We've made that decision, and we continue to make it, regardless of what you say or anybody says. But there are very big problems out there. And they choose to manifest themselves at not the most appropriate times. Not the most appropriate. But if you read Dr. Powell's example of her own niece, 14-year-old niece, in that case, in that situation, the medical end of it, the police having to be called, the police officer in good faith trying to do the best that he possibly could, but he had no training in mental health issues. And so he really didn't know what to do. It's not his fault. He wasn't trained. So we are talking about the frontliners today. The frontliners are the people, the witnesses that we've called to this committee. They're the frontliners. They see this day in and day out. And I bet you, Mr. Chairman, if we invited them back again a couple of weeks from now, they'd get deeper into it and be more personal about it, what they have to face day in and day out. But I looked at that example that was presented today. And there's so many things that you had to stop at the end of every line about this young lady, 14 years old. And if we could do anything, and what would we do? There's a number of things here throughout all the witnesses and what they had to say. The question of stigma. In New Jersey, there are signs on posts in municipalities of this is a stigma-free community. Man, is that a great thing to see. And while you say we can't do everything, I agree with you 100%. But we sure as heck could do something other than adjourn. How many times have we heard that? So, Mr. Chairman, I will not get annoyed. I will not retreat. The last 2 years made us painfully aware. Our witness, all the witnesses' testimony today removes all doubt of the mental health crisis we face. after listening to these folks, the frontliners, and you still walk away saying, well, your only response is the government can't do everything. There's something wrong with you. Tens of millions of Americans are suffering grievously from social isolation, fear of infection, job loss, burnout. There's stark statistics. And during the pandemic, more than 1 in 10 adults reported using alcohol or drugs to cope with the stress. Deaths from drug overdoses rose from 40% by 40% between 2019 and 2021, an increase of 29,000 people. COVID-19 laid bare the shameful inadequacy of our mental health programs. And we started so well to change it, as our friend from Wisconsin mentioned with Mr. Kennedy. And bipartisan support equals 50-50, that was. I remember it clearly in my mind as if it happened yesterday. Medicare, I've got to conclude, I know, but I want to get into this one last comment. Medicare beneficiaries face dangerous treatment barriers because Medicare is not subject to any parity requirements. And if we don't address that, we're not going to get to the heart of the issue and avoid the burnouts. Thank you, Mr. Chairman.
Thank the gentleman. Let me recognize the gentleman from South Carolina, Mr. Rice, to inquire. With the gentleman on mute.
Thank you, Mr. Chairman, and I'd like to direct my questions initially to Mrs. Avula, if that's possible. If we have any time, I'll move on. But, I used to run a homeless shelter in Myrtle Beach, South Carolina, and that's a destination for a lot of folks, and many of which, unfortunately, have mental health issues, and they came with children, and they came with substance abuse, and a lot of other things. And I've seen firsthand the effect of that on people and families and veterans and vulnerable populations. And, it seems that every year, Mrs. Avula, I'd like your opinion about something. I know there's probably no hard numbers on this, but is substance abuse a symptom of mental health, or is mental health a symptom of substance abuse?
I don't think that there's data to suggest one happens before the other. I think that's why it's so important to always screen for co-occurring disorders.
Okay, I look at the numbers, and this is something that's bothered me since I've been in Congress. Personally, I believe that a lot of our substance abuse issues originate at the southern border with cartels below our border. But if you look in 1999, the number of people who died from drug overdoses in the United States was less than 20,000. This year, it's going to be over 100,000. And it's not something that is new, and it's accelerating, and it continues to accelerate. Yet every year in Congress, we do new programs and put up new money, and it doesn't seem to solve it. It doesn't seem to even slow the issue. Do you agree with that, Ms. Avula?
So no, not entirely. I think if you look at some of the advances that were made during the last administration when we were working on combating the opioid crisis with a significant amount of resources from Congress on the state opioid response program, the substance abuse prevention treatment block grant, we did see major advances in increases in medication-assisted treatment. We saw a downturn in opioid overdose deaths. Obviously, a lot of those gains were lost during the pandemic, but I do feel like with collective effort and additional focused resources, we do absolutely see benefits from that. I would also encourage any resource that is provided to be flexible so that states can use it to meet their tailored needs, because every state is different.
Okay, and you kind of headed me off of my next question. That's good, because the one break in this upslope of substance abuse deaths, it started in 2017. 2017, 2018, 2019. It leveled off and actually started to drop a little bit for the only time in that 22-year period. And one of the things that happened there and I'm not trying to be overly partisan here, I'm just trying to point this out and see if there's any correlation or studies on this, is that we tightened down on the southern border and we stopped some of the flow of the drugs across the southern border. Do you believe that had any effect on it, Mrs. Avula?
Sure. So obviously, I'm on the demand side, so I believe that a lot of the strategies we put in place on the behavioral health services side in terms of expansion and things like that made a huge difference. But I think it stands to reason that slowing the supply also does impact people's ability to use substances.
Okay. Well, and I say that, every year since I've been in Congress, I've been in Congress for 9 years now. Every year we adopt a new program for drug abuse, and we put more money into existing drug abuse programs. And every year, except for that 3-year period, 2017, 18, 19, it seems to get much worse. So, and then on the flip side of that coin, we have some successes like telehealth. I represent a very rural district, and telehealth has absolutely impacted people who had no access to that type of treatment before. It's impacted my own family. My own family's had the opportunity and need to access telehealth, and it's been quite helpful. So I recognize that Congress absolutely should do everything we can. I think we need to be very focused about things that have been successful, and make sure that the programs we put in place, which are all good intention and trying to help people who very much need it, we use our limited dollars in the most accurate, pinpoint way that we can. And with that, I yield back.
I thank the gentleman. Let me recognize the gentleman from Illinois, Mr. Davis, to inquire.
Thank you, Mr. Chairman, for a very informative hearing. And I also want to thank all of our witnesses for the very insightful comments that they have made in their testimony and in response to questions. Ms. Saucer, it's been a pleasure working with you on child welfare issues. And I want to thank you for the interactions that we've had. We had a few weeks ago a child welfare worker who was killed working a case as he visited a home trying to help a family with a serious situation. Of course, that raised the interest significantly in terms of child welfare and the instance of how do we help make sure that the workers feel safe or have a sense of safety as they interact with their clients. Are there things that social service agencies perhaps could do that would be considered best practices for these individuals as they go about their daily tasks?
Thank you so much for your question, Representative. And we in Ohio were deeply saddened to learn about the Illinois caseworker's death. In fact, in Ohio, we just honored a 20-year anniversary mark of when a caseworker in Ohio was murdered in the line of duty as well. So our deepest condolences go out to you and everyone in Illinois. And as I had shared in my testimony, our children's services workforce is experiencing significant secondary trauma. Recent research showed that 53% of our caseworkers have some level of secondary trauma, and that level is meeting the threshold of post-traumatic stress disorder. So the fear that our caseworkers have every day going out to the field in terms of what traumatic experience they might encounter is real. The fear that they have going out to the field every day in terms of whether or not they will leave the home alive is real. And we believe that there are ways to enhance safety for our children's services workforce. Obviously, we provide very rigid training to our caseworkers, but beyond that, some of our county agencies have used a hotline app kind of thing to alert when they need to be connected to 911. Some our county agencies are using a teaming approach when they go out to the field, so they're not alone. Some of our county agencies also have to feel safer when they partner with law enforcement to go out to homes, especially when they're entering homes that they've never encountered before. And we believe that if we could work with this committee to expand 4E admin flexibility, we could further the supports that our county agencies can provide to our caseworkers.
Thank you very much. Dr. Powell, I was pleased to hear you mention mass incarceration in your comments. I live in the second largest county in the United States of America, Cook County, and our sheriff often says that he runs the biggest mental health program in the state, and that is the county jail. Dr. Powell, let me ask you, is there better ways? Of course, we need to reduce the numbers of people who end up in these situations, but is there a better way of treating them once they are, in fact, incarcerated?
Danny, I think you're muted.
I am?
Not any longer.
I think I'm okay. I'm not sure Dr. Powell heard me.
Go ahead, repeat the question.
Dr. Powell, I mentioned the fact that we have large numbers of people in county jail facilities, and it's a heavy group. Is there a better way of treating these individuals who have mental health problems, who are incarcerated, and really need mental health treatment? Maybe she's not there, and perhaps we would just, is there another member of the panel who'd like to take a cut at that question?
This is Ms. Avula. I would like to take a cut at that question. One of the major things that we did during my time at the Substance Abuse and Mental Health Services Administration was made mental health block grant dollars flexible enough to be used in a jail setting. A lot of federal dollars cannot be used in a jail setting, and that is a major problem. I strongly recommend that that be looked into. We were able to do that with a policy change on the mental health block grant. On the substance abuse block grant, we are still, as a state, I am not allowed to use that funding within the jail setting, and we know there are a lot of individuals who need substance use disorder treatment. One of the other things we're doing in North Carolina is doing competency restoration demo pilots with our jails and community-based treatment centers. I think that the linkage between community-based care and jails and prison is very, very critical. Often this is thought about only in the context of reentry. That is not enough. We have to do it during the time in which the person is incarcerated. It's very critical to ensure that individuals with mental and substance use disorders are getting care and services during the time of their incarceration. It will lead to a much more successful reentry into society. The other thing we should be looking at is Medicaid reimbursement and getting individuals back on Medicaid rolls as quickly as possible once they are released.
Well, let me thank both of you very much. Anyone else?
Why don't we proceed to the next witness, Dan?
Thank you, Mr.
Thank you, Mr. Davis. So let me recognize the gentleman from Arizona, Mr. Schweikert, to inquire.
Thank you, Mr. Chairman. And you said something actually in your opening remarks, complex subject and probably complex solutions. I also believe this is another subject area we probably should have been in the back room all around the table with experts on a big whiteboard because in some ways we're incentivized to get behind these mics and sort of do anecdotal stories instead of try to look at our data sets. I'm trying to actually, because we're seeing something in the Phoenix area that I think is actually very concerning. We've been looking for the actual numbers right now, but some preliminary numbers are showing a dramatic increase in homelessness. At the same time, we're seeing a fairly dramatic increase in substance abuse, overdoses, and some information the other day when I did a police ride-along saying that some of the narcotics, particularly fentanyl that's available in the street, actually has gotten dramatically less expensive. So it's back to your opening comment of the world's complex. When we talk about mental health issues, are we talking about the suburban family? Are we talking about the increase in those living on the streets? And is that a combination of mental health issues? Is it substance abuse issues? Is it the chicken and egg? And Ms. Avula, if we wanted to try to find some good quality sort of data extracts to say, here's the best data we have on homelessness, mental health issues, populations, association with narcotics, and then we wanted to see sort of the whole abstract. Where do you go as a policymaker? Where do we actually find real math?
So there is a coalition on homelessness that brings together different departments that looks at this. So
And I know I'm interrupting you, but I want to go much more than just homelessness. It's almost in the entire mental health space because we're trying to understand
that's right.
where the resources go.
That's right. That's right. It looks at all of these issues. And I think, HUD is the keeper of that information in terms of bringing together all of these components. I will say the collaboration at the federal level, while it has improved, it's not perfect. So there is unfortunately not one source of data on this topic. Exactly what you're describing kind of happens is it's sort of piecemealing and putting it all together. But when you do that, you can see that there is really a need for a comprehensive strategy to bring all of these pieces together to, in a holistic way, address the problem. You are not going to be able to solve this problem just by addressing substance use disorder or just by addressing homelessness. You have to be able to do multiple things at the same time.
Well, you're actually going down the path I was fascinated with. Is maybe our first step is to understand the problem, understand the scale of the problem, understand are there any models out there working, and the third thing I wanted to touch on is over the last few years, and we have a little binder of some of the articles, there's actually been dramatic improvement in pharmaceuticals for those who are severely mentally ill. There's even some delivery devices where it's under the skin, where it's a slow leach to a passive RFID that allows you to know that the patient has actually swallowed the pill. As we've tried to understand the scale of the problem, where the problem is, where we can have impact, how much is, because being from Arizona, our borders open, we see streaming of not only humanity, but narcotics coming across. We can see with inflation, our housing is just crushing those at the lowest tiers, and now we have people living on the streets. Are there hope that also we may have not cures, but ways to help stabilize populations so they can function in society? Where do I go to find this information?
Yeah, 100%. There are evidence-based practices and programs that are very well evidenced to treat serious mental illness. And we know that a big portion of individuals that are homeless also have serious mental illness. So things like assertive community treatment programs, things like the psychotropics you mentioned, those are ways in which serious mental illness can be treated. Again, there's a very strong evidence base for it. Things like the CCBHC model, which is the integration of care, that's also geared towards individuals with serious mental illness. SAMHSA has evidence-based program repository. All of these evidence-based practices are listed on there, and how you implement them is also listed as well, in case communities in your district would like to implement them.
Thank you. That's actually quite helpful. And with that, yield back, Mr. Chairman.
The gentleman's point is well taken. The use of the shot, for example, for those who are severely mentally ill, so you know that the medication is being taken and administered properly. There are those who, many psychiatrists will say that once somebody starts feeling a little bit better, they stop the medication, they reject the pill, and the number now of confrontations between police and those who are mentally ill, in very dangerous moments, incidentally. It's not as simple as the cop didn't do this or didn't do that. It's what happens when the confrontation actually takes place in those seconds. And I think that explanation that you offered was right on target for a more encompassing effort to reach those who are on the streets. And you and I, while we don't share the same congressional districts, I can predict safely that the mental health professionals where you are and where I am, they will all say one thing that's very similar: not enough beds. Not enough beds. So I thank the gentleman. With that, let me recognize the gentlelady from California, Ms. Sanchez, to inquire.
Thank you, Mr. Chairman. It's been more than 2 years since the first cases of COVID-19 were confirmed in Southern California. And since then, families have faced a wave of challenges and stressors that have contributed to, and in many cases exacerbated, our country's mental health crisis. Job losses, social isolation, burnout, and uncertainty about what tomorrow may look like have all impacted families in profound ways. As the COVID-19 pandemic and mental health challenges continue to take a toll on millions of Americans, it's children, women, and communities of color who are carrying a disproportionate burden of this crisis. And there's no doubt that the mental health crisis will be with us long after the COVID-19 pandemic. And that's why I'm alarmed to hear that even now our healthcare system cannot keep up with the increased need for mental health services. We've already begun to see the economic and health impacts of this crisis. Frontline workers are leaving their jobs due to burnout and exhaustion, resulting in workforce shortages across clinical and human services. Americans are reporting increased rates of alcohol and substance abuse and worsening chronic conditions, and families are struggling to access the care that they need. Barriers and gaps in access to care persist across Medicare and private health insurance, and too many Americans are falling through the cracks of our fragmented mental health care system as a result. And it's just simply not acceptable. It's not enough. Though Congress has taken steps to close gaps in Medicare coverage for therapy and substance use disorders, significant work remains to ensure that older adults have access to the care they need. Staffing shortages coupled with coverage limitations in Medicare have made it difficult for safety net providers like TCC Family Health in Bellflower, California, to serve some of the most vulnerable members of the community. Clinics and agencies simply don't have the staffing to address the complex needs of patients. Ms. Steinberg, in your written testimony, you discussed gaps in Medicare coverage for behavioral health services. What are some of the most glaring barriers that prevent Medicare beneficiaries from accessing critical mental and behavioral health services?
Thank you for your question, Congresswoman, and that's exactly the right framing. It's you described how these costs are getting shifted to safety net providers because they're not being covered in Medicare. That's exactly right. The lack of coverage of evidence-based services, providers, and settings is the most glaring barrier to Medicare beneficiaries from preventing them from getting the services that they need. That's one of the reasons that care can't be integrated. If these things aren't covered by insurance, people can't access them. You can't integrate them into mental health care, and you can't integrate them into medical care. Financial barriers, including insurance not covering treatment, was one of the most commonly reported reasons that Medicare beneficiaries did not get the treatment that they needed, according to the National Survey on Drug Use and Health. But the lack of parity is really another glaring barrier, because even when services or providers are covered under Medicare, treatment and access are still more limited. And we have heard from Medicare beneficiaries who, lose access to treatment that they need because there are quantitative or non-quantitative barriers to treatment. So, for example, inpatient or hospital-based care is a covered service, but there is a 190-day lifetime limit on inpatient psychiatric care, while there's no such limit for any medical condition. This is especially problematic for individuals who become eligible for Medicare before age 65 due to disability, and those who have chronic psychiatric conditions that may require multiple hospitalizations over the course of their lifetimes. And since those lower levels of care are not covered, people with these conditions are more likely to be hospitalized to receive care, but then they can lose access to this otherwise covered benefit because of this discriminatory quantitative limitation. But we've also heard from beneficiaries who lose access to treatment even sooner because of burdensome and unnecessary utilization management practices, which are some of the non-quantitative treatment limitations that are barriers to care. And folks have already mentioned these prior authorizations are one of them. Patients who've been on medication for a substance use disorder for years still need to get an authorization every month. And there's data how, removing pre-authorizations for one medication for opioid use disorder was associated with more people receiving treatment, as well as fewer hospitalizations and emergency department visits. So these are some of the ways that, expanding coverage gets people care, and applying the Parity Act to Medicare ensures that that care can be received comprehensively and equitably. Thank you for the question.
Thank you. My time is running out. I just want to flag two more issues. One is that we often don't have providers who have the same language skill set as the need for the patients that they serve, so that folks with limited English proficiency often have difficulty accessing culturally and linguistically appropriate care. And I also want to mention the impact that school shootings have on children's mental health, and the disturbing trend and increase in school shootings, and how that affects the mental health of students across this country. And I want to thank all of our witnesses for their testimony today, and I yield back, Mr. Chairman.
Thank the gentlelady. Let me recognize the gentlelady from Indiana, Ms. Wolarski, to inquire.
Thank you, Mr. Chairman. When Ways and Means members work together on issues in a bipartisan manner, we deliver for the American people. When Democrats go it alone, we're left with predictable long-term crises. Democrat one-party rule has given us an inflation crisis, a workforce shortage crisis, a supply chain crisis, a border crisis, crime crisis, COVID testing crisis, and a national security crisis. And now add America's mental health crises to the list. At the height of the pandemic, I proudly partnered with Subcommittee Chairman Davis to author meaningful legislation to support foster youth and families, along with at-risk pregnant women and mothers and kinship caregivers, such as grandparents raising grandchildren. These Americans already face unique challenges in normal times. The pandemic has only added to these obstacles, but thanks to our bipartisan work, we delivered real help. We equipped states with the resources they needed to support case managers, social workers, shift to virtual caseworker visits, and protect youth from aging out of foster care. The difference is clear. When we work together, Americans are better off. When Democrats go alone, America falls behind. When this committee took up Democrats' massive COVID bailout, we made it clear their priorities missed the mark. We should have immediately incentivized people to get back to work. Schools needed to be open. Parents needed to be empowered to make decisions for their families. Today, many schools have still not opened. They have still not returned. Children are suffering irrevocable learning loss. School isolation and school closures have a steep price. Last year alone, more than 100,000 Americans died from drug overdoses. That's 100,000 families that have absolutely been impacted. This is what happens when people are isolated and you take away an individual's incentive to provide for their family. Right now, Child Services and Mary Lee Allen Promoting Safe and Stable Families program are scheduled to expire without action from this committee. We should use this priority to strengthen family first implementation, prioritize grandparents and kinship givers, and make sure our frontline caseworkers have the tools they need to get their jobs done. Ms. Strasser, what lessons can we take from the pandemic to help to inform our upcoming work on reauthorizing these child welfare programs, particularly as it relates to the mental health of children? And then quickly, Ms. Strasser, after 10 months, the Treasury has finally finalized a rule on how states can even use their coronavirus relief funds. The rule specifically allows states to use funds for increased pay, benefits for essential workers, including child welfare workers, which, as we heard today, could go a long way in addressing worker burnout. Now the Biden administration is pushing for even more federal relief spending, even though state revenues grew by 14% from fiscal year 20 to 21. Ms. Strasser, do you have any idea if these federal resources are being used in Ohio or any other state to address the mental health challenges facing child care caseworkers?
Thank you so much for your question, and thank you for your attention to children's services issues. We appreciate it. As the COVID relief funds, in addition to the funds that states received, counties received, as you all know, direct allocation of relief funds. So I will speak to the funds that counties received, since I am representing counties today. Counties are investing these funds in a full range of services, targeting essential workers, such as public health workers, law enforcement workers, human services, et cetera. And in my written testimony, I highlighted some examples of how counties are using the COVID relief funds, particularly supporting the child welfare workforce. And counties are using the COVID relief fund for immediate COVID response, such as vaccinations, helping businesses get back on their feet, and other immediate needs that the pandemic has caused. And if you're interested in more information on how counties are using the COVID relief fund, NACO has a database that you could look at. Go to your Title IV-B question because of time here, but as you consider reauthorization of Title IV-B, it does open additional flexibility on how states and counties could use those funds to address the mental health needs that are facing our workforce. However, some jurisdictions, Title IV-B remains at the state level and does not come down to the county level. So in those jurisdictions, they would not be able to use that vehicle to support their workforce. But we hope we can work with you and members of this committee to think about other vehicles that we could leverage to really support our workforce that's struggling.
I appreciate it. Thank you, Mr. Chair. I yield back.
Thank the gentlelady. Let me recognize the gentlelady from Alabama, Ms. Sewell, to inquire.
Thank you, Mr. Chairman, for hosting this hearing on the ongoing mental health crisis in the United States. I proudly represent Alabama's 7th Congressional District. It is a district that is largely underserved urban communities as well as rural communities, largely African American populated. A top priority for me has been addressing and reversing the trends that have made the communities I represent the most at risk for mental illness and substance use disorders. To no surprise, the COVID-19 pandemic, as has been said, has really laid bare the systemic disinvestments that have been made in both mental health and substance abuse. Increasingly, I think we have seen that race does have a factor and does play a role in mental health. And so my question is to Ms. Powell, if you could address whether or not race plays an issue in mental health and substance disorders, and if so, how can we have more equitable solutions to address such a problem?
Thank you for the question. I want to make it clear here that when we talk about race, we have to recognize a couple of things. One, that race is a mythic but powerful sociological invention. There are no data to suggest that there are biological differences, with respect to race or ethnicity that would instigate differences or disparities in mental health outcomes. What we see, though, are the consequences, the byproducts of social experiences of race. One of the things we know from decades of scientific research is that racism is a biopsychosocial stressor that many people who are existing in marginalized communities face. And racism produces effects that are physiologic, that are psychological, and that affect the well-being of individuals in really pronounced ways. And one of those things that we often see that is largely unacknowledged by the clinical community is racial trauma. And these are the traumas that can happen not just as a consequence of your direct exposure to racism, but also secondary exposure, or what we call vicarious trauma. And yet our clinical and diagnostic tools fail to list racism as a viable source of trauma for folks. And that has implications for our training enterprise. That means that clinicians are not prepared to address, detect, or respond to racial trauma that presents among populations. So we also know that there is a longstanding and documented history of unequal treatment among Black, Indigenous, and people of color by healthcare providers. And those of us who work alongside medically underserved communities know this well and have been working to advance health equity so that we can recognize
Thank you, Ms. Powell. I actually have another question as well. I apologize.
Yes.
I also wanted to ask a question of Dr. Johnson. First, I want to commend the Commonwealth Care Alliance for its thoughtful drug management program, whereby you monitor your members for risk of opioid abuse and tailor pain management accordingly. How, I actually have a bill, the No Pain Bill, and it stands for Non-Opioid Prevent Prevent Addiction in the Nation. This bill would allow for Medicare to cover alternatives to opioid use. Can you talk a little bit about how effective this has been in reducing the risk of opioid abuse?
Thank you for your question. So without a doubt, one of the most complicated situations that we often deal with are individuals who have co-occurring conditions, such as both an opiate use disorder and pain management. So I would like to say just from the beginning that that opiates do have a place in obviously the treatment of individuals.
But we do have non-opioid alternatives, is that right?
Yes. So I just wanted to be foundational in just indicating that there is a place for opiates, and I just wanted to be clear about that. But yes, there are many alternatives to opiates, both in the pharmacological space in terms of using some medications that are not addictive and have the kind of risk that's associated with opiates. There are also a whole range of non-pharmacological strategies that we use at CCA. And
now, those non-opioid alternatives are often not reimbursed, yet clinically they have been effective in helping with substance abuse. Mr. Chairman, I just wanted our committee to work on trying to find funding for, on the one hand, racial trauma being one of the indices that can be reimbursed for mental health, and secondly, on non-opioid alternatives also being acknowledged and reimbursable. Thank you, sir.
Thank the gentlelady, and pleased to take up the challenge. With that, let me recognize the gentleman from Ohio, Dr. Winstrup, to inquire.
Thank you, Mr. Chairman, and thank you all for testifying today with us. I'm glad we're here today to talk about the mental health crisis in our country, because the mental costs of COVID-19 lockdowns have manifested in everything from depression to domestic violence to substance abuse and suicide. There's a veteran from my area, bilateral lower extremity amputee. He was making his way through his TBI and everything else. His last Facebook post a year and a half ago was an empty refrigerator with 2 bottles of water and an empty box of an empty pizza box, and then he took his life. But see, it's not March 2020 anymore. We have vaccines, we have therapeutics, and it seems like the administration is still just focusing on what epidemiologists have to say and not our overall health, not only our health as a nation, but individuals' health. And we need to move on, because failure to do so, we don't make diagnoses we should be making. And it exacerbates the mental health crisis that we're seeing in our country today. And I think it's particularly acute for children. And I've spoken personally to many parents across the country, and the stories are painful. You know, we see plummeting grades, children struggling with depression, social anxiety, eating disorders, and even suicide. And so, you know, many we see, you know, the teachers' unions still seem focused on keeping our students out of schools and masking our children, but they don't care about the impact it has on their lives. My son is in 2nd grade, and he's been in school. They've only canceled 2 days, and they canceled 2 days because too many of the teachers had the Omicron variant that's going around now. But otherwise, they've been open and doing well. And, you know, I think Ms. Saucer referred to the importance of a supportive community. Well, that's what the school is. And so that's all part of mental health, to have a safe, stable family and a stable community where they can be together. And I think this is incredibly dangerous, and I hope we keep making that point. So we can tackle some of these issues on a bipartisan basis, that's for sure. Representative Kildee and I have the Rural Behavioral Health Access Act that provides telehealth services in rural areas and emergency departments, well, in any emergency department, especially in rural areas, to improve access to essential healthcare services. And I've seen one model in Ohio where you had a one-stop shop, if you will. You go and you see your behavioral health provider. You also see the doctor in charge of your physical medicine, whether you have diabetes or any other disorder. And also you get all of your prescriptions right there. And certainly that increases compliance and better outcomes. And I think we should continue to look towards that. And you add something like that and add the convenience of telehealth and even the telephone. That's how we did it for years as doctors. We took care of a lot of patients over the phone. So many of the rural areas in my district, they're still grappling with substance abuse, which has been a problem. If you've read the book Dreamland, that is my district on the cover. Ms. Avila, I know you previously worked at SAMHSA during the Trump administration, oversaw implementation of the Support Act. And as the pandemic has taken stage, we've not really had an opportunity to have any oversight hearings on that. Is there anything that you learned during your time there implementing the Support Act that Congress should use to inform continued efforts to address substance abuse?
Yes, thank you for the question. I think one of the major things that the Support Act helped us to do was really put in place a comprehensive strategy. As was noted before, there was only a one time where we saw a drug overdose deaths decrease. There was such a concerted effort, again, really framed in the Support Act to say increase medication-assisted treatment, increase naloxone, look at prescribing practices, get out there alternatives to opioid prescribing. I think in terms of looking at those strategies and seeing where they are today, I think is incredibly important. I also think it is extremely important, and this probably I know now more from my experience today, is really allowing states the flexibility to design the strategies they need to work in their local jurisdictions. The federal government cannot design a one-size-fits-all strategy. We know what the best practices are in the federal government. We know what the evidence-based practices are, and we should require them at a federal level. I 100% support the federal government requiring evidence-based practices, but then leave the flexibility of the implementation of those practices to work in the communities where they are being implemented. I think that's very important. The other thing I will say quickly is I think an all hands on deck approach is needed. I think you have to include peers, you have to include professionals, you have to include families. It really is, everyone has to be involved in this. We are not preventing and treating substance use disorders from our office in Rockville, Maryland, or office in DC. That's happening on the ground in your districts. And I think we need to make sure that communities are equipped and engaged in this conversation.
Thank you very much. Yield back.
Thank the gentleman. Let me recognize the gentlelady from California, Ms. Chu, to inquire.
Thank you. Ms. Steinberg, as one of only 2 psychologists in Congress, this whole topic interests me very much in multiple ways. So I want to thank you for your testimony highlighting the gaps in our system when it comes to covering substance abuse disorders in Medicare. And I'm proud to be working with the Legal Action Center to develop legislation to close these gaps in Medicare, where we find that Medicare largely does not reimburse for substance abuse treatment in so many ways. And in fact, your testimony in the Legal Action Center's recent report highlight truly outrageous gaps in our mental health and substance abuse treatment coverage for beneficiaries. We know that mental illness and addiction do not stop suddenly at age 65. And so neither should our health policies. So, Ms. Steinberg, your testimony mentions a number of areas in which Medicare beneficiaries face gaps in care for substance use disorders. Can you explain why Medicare's exemption from the 2008 Mental Health Parity and Addiction Equity Act leaves beneficiaries without care options, and what does this look like in practice?
Yes, thank you, Representative Chu, and we're thrilled to be working with you to improve access to substance use disorder treatment in Medicare. So the fact that the full evidence-based continuum of care for substance use disorder treatment is not covered in Medicare would be considered a parity violation if it were applied, because the full continuum of medical services are covered. In addition, it would be a violation for there to be limited coverage of providers and facilities for mental health and substance use disorder services, because plans cannot impose different rules for the inclusion of providers, their coverage, or admission to networks. Medicare Advantage plans would be required to use comparable network adequacy standards and practices. So we would not see these same disparities where people disproportionately cannot access the mental health and substance use disorder care they need from in-network providers. Plans could not impose stricter utilization management practices for these services. And perhaps most importantly, reimbursement rate setting practices would need to be comparable for mental health and substance use disorder services. So we would finally be paying these providers the rates they need to treat their patients.
Thank you so much. Also, let me ask about, Ms. Steinberg, your testimony about the lack of available mental health providers across the continuum of care, which I think is a critical gap in our current healthcare system, especially as patients leave active treatment and enter recovery. That's why I've worked with my colleagues on this committee, Representative Adrian Smith, to introduce the Peers in Medicare Act. A peer support specialist is a person who has lived experience, who has been trained to support those who struggle with mental health, psychological trauma, or substance abuse. Peer support supplements mental health professionals as part of a care team to help someone struggling with substance abuse or mental health disorders on the road to recovery. So our bill would define peer support specialists in federal statute and clarify that nothing in current law prevents peers from being included in Medicare's psychiatric collaborative care services. And so, Mr. Chair, I'd like to submit this letter from the Association for Behavioral Health Wellness, the Depression and Bipolar Support Alliance, Mental Health America, and National Association for Peer Supporters and the National Association for State Mental Health Directors supporting the Peers in Medicare Act for the record.
So ordered.
Thank you. So, Ms. Steinberg, can you discuss how the utilization of additional specialists like peers can help alleviate the burden on provider care teams and help providers serve more patients in the Medicare population?
Yes, absolutely. Peer support is an effective practice. It's evidence-based, and there's data that it reduces hospital admission rates, it increases social support and social functioning, and it decreases substance use and depression. As you indicated, peers complement existing providers. They round out the treatment team. They can work in emergency departments and other places to help get people the support they need and connections to care. They help people engage in services. They help people manage physical and mental health and substance use disorder conditions, build support systems, and live self-directed lives in their communities. Furthermore, the majority of states allow Medicaid to be billed for peer support services. So this is another example of where people lose access to their services and supports when they turn 65 or become eligible for Medicare because of this current barrier.
Thank you. And I want to address one last issue, which is that psychologists cannot practice independently under Medicare. And so that's why I'm introducing the Medicare Mental Health Access Act, which would increase the number of psychologists available to patients in a very practical way. And I yield back.
Thank the gentlelady. Let me recognize the gentleman from Texas, Mr. Arrington, to inquire.
Thank you, Mr. Chairman, and to the witnesses, thank you for your time and for your insights. Very important issue. I agree this has been a systemic problem for our country prior to the pandemic. I also agree the pandemic has made that challenge even greater and the situation worse. I will also say that government's response has also exacerbated the situation. And so when I approach an issue like this, I generally want to know what is driving it as opposed to the symptoms, because I think often as lawmakers and people who have a heart for serving our country and our fellow countrymen, we want to do something to help. The problem is sometimes the cure is worse than the disease, and there are all sorts of unintended consequences. And I think we've seen that, unfortunately, in spades post-pandemic because of government intervention that has had unintended, I would suggest, but serious adverse implications for the folks that we're all trying to help. I like what Ms. Saucer's organization stands for, their mission, safe children and stable families. And what better objective to have in front of us as we work through these things than those two in strong communities. But as I look at this post-pandemic and the things that we've done to make the situation worse, I think about the following. I think about the lockdowns and the school closures, for example, that professionals and other members of Congress warned there would be far greater negative impacts down the road. And there was a time when we didn't know, there were so many unknowns. We were all trying to do our best to address it. And then there was the time, and I think that we're in today, where we know a whole lot more. And one thing we know is this is going to be with us for a while. Some version of this disease will be with us, and this virus. And so we've got to learn before we make things even worse, and no matter what the motivation is. Inflation, for example. To think that 1 in 5 people cannot pay their heating bills makes it no surprise to me that we have greater mental health challenges and substance abuse and addiction and suicide rate increases. To think that the crime that is rampant in our country and homicide rates at all-time highs, it's no wonder that our children don't feel safe. To focus on the most vulnerable. The people in the most vulnerable neighborhoods feel the least safe. And the drugs, 100,000 overdoses. You know, I know there's a demand issue to deal with, but when we know 100% of the drugs are coming across the border and that fentanyl seizures are at an all-time high, 3 times that of the previous year, and yet we continue to allow the cartels to have total control of our border, and we do nothing. We do nothing to stop it. And I think it's a shame because you've got half of the overdoses are fentanyl or opiate related, and it's an absolute disaster. So I understand there's some things we've got to do pre-COVID, some things that are driving this. But I look at the most obvious things that I think most Americans see and scratch their head. If you spend this money like you're spending it, if you lock labor out, you're going to cause inflation to go up, and people are going to literally lose hundreds of dollars every month, money they can't afford if they're going to make ends meet. I'll just tee this one up and stop going on this tirade over our self-inflicted problems with respect to mental health. Ms. Avula, can you talk about the drivers, not the symptoms, but the drivers of what's making this crisis worse and how to prioritize that as public policy and lawmakers so that we can actually do something to help our fellow Americans? And I know I'm out of time, Mr. Chairman, and I apologize for going too long.
I think we should let the witness answer the question briefly.
Thank you.
Thank you, Mr. Harrington.
Thank you. I think there are a number of drivers, many of which I think you've referenced. I think unemployment is a big factor. I think financial instability. I think racial disparities in access to care. I also think that a lot of the factors that we've been talking about that have been affected throughout the pandemic, so isolation, loneliness, grief, trauma, all of those factors can contribute to increases in mental health symptoms as well as substance use.
Thank you for the indulgence, Mr. Chairman.
I thank the gentleman. Let me recognize the gentlelady from Wisconsin, Ms. Moore, to inquire.
Thank you so much, Mr. Chairman. And let me just thank all of the witnesses and our members for a very, very productive morning of discussion. I'll just have to admit that this hearing has been very depressing. No pun intended, to just hear about the disconnected mental health system. You in particular, Attorney Steinberg, really brought it to my attention, you and Ms. Chu, at how the mental health parity provisions are not required under Medicare. Every single one of you have talked about the impact on youth and kids in foster care. And of course, most children are not dual eligible, and foster kids are not dual eligible for services. But you've all talked about the importance of an integrated system, and there's so many. I guess maybe I'll start with Dr. Wisdom Powell. When we talk about the disparate disparities between, say, people of color and other people, it's not only the financial inability to access that care, but right now we're dealing with the behavioral health problem with opioids. And back in the day when Black people were on crack cocaine, it was a crime. That kind of disparity, access. We talk about rural areas, Native American. I would like to hear a little bit about what's happening on Native American properties. I know that we have problems with clinicians in Indian country, primarily because we don't provide the same sort of financial and tax-free scholarships for Indian Health Services. And again, I've tried every year since I've been in Congress to get social workers in every school, recognizing that intervention with young people is really important. How do we integrate a system such as this? And maybe I'll start with Dr. Wisdom Powell, and then move it on to Ms. Steinberg. Thank you.
Well, thank you for the question. And I want to do to a couple of things. First, interject a little bit of positivity into the conversation. I'm a positive psychologist by training, and I'm radically optimistic about our potential to solve this problem. One of the things that gets in our way is the midst of complexity. And I'm here to remind us that we are mapping the human genome. We're sending humans to Mars. We've created an integrated communication system that allows us to communicate with people from around the world. We can solve this problem. And one of the reasons I'm optimistic is because of our youth and because of their ingenuity. Youth are turning to digital health platforms, to social media, to other sources for mental health information. And while that's not entirely a pure way to get that information, they are agentic. And like my 14-year-old niece, they're not going to stand by and wait for systems to help them radically heal. We integrate by, first of all, looking at the spaces and places where youth congregate, and we figure out how to infiltrate those spaces. In my work as a psychologist and as a public health professional, we've been infiltrating barbershops, bringing that information to people, meeting them really purely where they are. We also know that we can do a lot with our systems if we, in fact, align them in ways that allow systems to talk to one another. Youth don't just interface with schools, which is a primary site for their support, but they also interact with churches, with community elders, with other systems. So we have to look at all of those options for helping them navigate their ways to better support. And I'll stop there so that my other colleagues can chime in.
Thank you, Ms. Steinberg.
Thank you. Yes, I completely agree. I think one of the ways we can treat Medicare beneficiaries, but especially Black, Indigenous, people of color in Medicare, is by bringing care to their communities, to where people are actually living. And again, one of the biggest barriers is that community-based settings other than opioid treatment programs are not covered. So people are forced to go to hospitals, which are more intensive, more costly, or they're getting insufficient care in office-based settings. And we know routinely that office-based settings are not where most Black beneficiaries are going. They're more likely to be going to emergency departments because they're not getting these lower levels of care in their community. So again, we need to be covering the evidence-based practices, as other speakers have said. If we cover the evidence-based practices in Medicare and we cover them in the communities, we will be bringing people the treatment that they need.
Thank the
So many
gentlelady.
questions, so little time. I yield back, Mr.
I thank the
Chairman.
gentlelady. Let me recognize the gentleman from Georgia, Dr. Ferguson.
Thank you, Mr. Chairman, and thanks to all the witnesses today. Thank you for your time and expertise. Mr. Chairman, I'd like to enter into the record two things. Number one, a full report from Johns Hopkins. It's a literature review and meta-analysis on the effects of the lockdown on COVID-19 mortality.
So ordered.
And also an article by Paul Best with Fox News summarizing this. And just a couple of highlights in this. It said that the lockdowns only reduced COVID-19 mortality by 0.2%. But there were some unintended consequences of this. Then many of these things have been highlighted so far today. The astronomical increase in opioid deaths, over 100,000 in 2021. Also an increase of 8.1% in domestic violence reports after the lockdown orders were issued, and the fact that 97% of U.S. teachers said that their students had experienced learning loss during the coronavirus pandemic. These are some devastating and unintended consequences of what is a real overreach of the federal government into people's lives. I want to speak.
So ordered.
Thank you, Mr. Chairman. So I want to speak or talk about this from the standpoint of being a parent and someone in a community that has dealt with mental health issues. One of the areas that hasn't had a lot of discussion today, and one of the real deficiencies that I see, is the real problem that occurs when there's a crisis moment with a young person, when they either tell a counselor or they tell someone at school that they intend to harm themselves. And they go immediately into the crisis mode. They go to the emergency room, sometimes waiting 24 to 48 hours to have someone evaluate the young person. Then there's the problem of trying to get them into an inpatient setting for stabilization, and then there's a real gap that occurs from the time that they leave the inpatient setting into when they can get into real long-term counseling, whether it's in person or whether it is whether it's remote learning. On telehealth. So I think that while we've talked a lot about access to care, and we've talked a lot about telehealth, and and there are just a plethora of comments and reasons why this has been exacerbated, and clearly the workforce issues around having enough providers for mental health treatment are real. I'd like to hear from the witnesses on this crisis moment that seems to be even worse in rural communities. So, Ms. Avula, if you could comment on that or give me your perspective on the real gap that exists in that crisis moment, the acute problem, and the transition from that to a safe environment to long-term treatment. If you could address that, I would be interested in your comments.
Sure. I think one of the issues, the major issue here, and you've characterized the issue quite well, and I think all states are facing this, is that there is not a substantial community-based mental health infrastructure or system across the country. So what happens in a moment of crisis, people call either the police or they take their child to the ED. The vision of 988 is that you should be able to contact this phone number and you should be able to be connected immediately to mental health services. I have deep hope that that will work. The problem is if a child needs very acute care, you still need a place to be able to take that child. So there are things like emergency respite. There are things like mobile crisis teams. There are things like that can be put in place in communities that will help alleviate the moment of the crisis so that the child can be stabilized and not, withstand and 48 hours is likely on the shorter end. Children are spending way more time in EDs. So we need to be able to immediately get the crisis moment stabilized. But then you're right, we do have the next problem of where do we then take the child for longer term care. So this speaks to, again, the need to continually expand and enhance the services that are being provided in the community to ensure that individuals are getting the care that they need. The other thing that
Ms. Avula, if I could, before I run out of time, I also want to point out that this is a real problem moving from in rural communities, because most of these treatment facilities are in metropolitan areas. There's certainly not enough capacity in the rural areas, and all of a sudden someone's got to be transported by an ambulance to the facility. And the parents or the caregivers or guardians are then sometimes hours away, and they've got to go back and forth. This is a real concern, and I think if we're going to be really effective in this, we're going to have to address this acute this acute care problem in those crisis moments, particularly in the rural communities. And with that, Mr. Chairman, I yield back.
I thank the gentleman. Let me recognize the gentleman from Pennsylvania, Mr. Evans, to inquire.
Thank you, Mr. Chairman, and thank you for this hearing. I'd like to ask Ms. Saucer, I think I got her name correct. Didn't get it correct. I want to ask her and ask Dr. Powell. Ms. Saucer, how could the federal government better serve frontline children welfare workers as they strive to provide high-quality service that address children mental health and behavioral health needs? The other question I'll ask you, can you highlight local children welfare agencies that already are offering mental health support and expand on how those services might improve workforce? And I'll go to Dr. Powell. Hello?
Yep. Did he finish his question?
Ms. Ant?
Thank you for the question. So my testimony has a recommendation on how this committee and the federal government could assist with our frontline workforce, and that would be to allow greater flexibility in Title 40 admin funds. Currently, we are not able to use Title 40 admin funds to provide direct supports or services to our workforce. The purpose of those admin funds is to provide direct services and supports to children that we serve. If we have the flexibility to use those funds to also provide direct support and services to our workforce, we would be able to provide them with trauma-informed counseling. My testimony showed some examples that some counties are being very innovative in supporting the workforce, such as having a clinician on staff to assist workers who experience secondary trauma, to having peer support groups, to doing trauma-informed supervision. So this would allow us to support our workforce, address the secondary trauma that they've experienced, as well as then retain our workforce, which we absolutely need to do due to our significant turnover issue that we have within child welfare.
Dr. Powell, if you could do one thing that would have the broadest impact, specifically improve the challenge you described in terms of your needs, what would you do?
This is a really challenging question, but I'll do my best to answer it, because I think that this is a wicked problem we're facing. And wicked problems are always those ones for which there is no singular solution that might work. But if I could do one thing, I probably would focus in this moment on addressing the democratization of mental health care. One, because as we've been pointing out in this important hearing, we are not in a situation in our current mental health system to really address the challenges. In fact, we have a design flaw. It's not really set up well to meet the needs and demands of a rapidly evolving populace. And so we have to think about what innovations might we bring to scale that would help to bridge or mind the gap. And we know that youth in particular are relying a lot on digital services and supports. So our question always is, in a rapidly scaling, sort of emerging digital mental health environment, how might we develop and adopt some standards and quality, some safety and quality standards that would help us to be able to scale those interventions in a way that would ensure patient safety? Again, I think that those interventions hold significant promise for us now and in the future as we move towards a more sort of tailored way of delivering services and actually reaching people where they are. In the state of North Carolina and Connecticut, we are utilizing digital mental health to deliver mindfulness-based stress reduction strategies to Black men and boys who reside in some of our most challenging, disadvantaged neighborhoods. And we are disrupting the effects of racism in real time by providing social emotional support, affect regulation support, and also direct stress reduction support, because we know those men are not going to show up in traditional clinics. So I think that there's significant promise that lies there, of course, with regulations and monitoring for progress and outcomes. But I think we have to move beyond this one patient at a time, one family at a time delivery model that we have been plagued with for so long.
Thank you. Thank you, Mr. Chairman. I yield back, bouncing my time.
I thank the gentleman. Let me recognize the gentleman from Kansas, Mr. Estes, to inquire.
Well, thank you, Mr. Chairman, and thank you for all of our witnesses for participating today. I mean, we've got to work on addressing America's mental health crisis and not just assume that we can ignore it, it'll go away, or allow our county jails to be the repository for individuals who are having an issue. I hope as part of that we'll have an open and honest discussion on the toll that some of the harsh COVID measures have had on the mental health in our society, especially the effects they're having on our children. You know, as we talk about the terrible rise in mental health issues, including cases of anxiety and depression and a rise in substance abuse disorders and suicide, I think it's time we address the fact that many of these measures were clearly causing this issue and have no end in sight. For 2 years, Americans have been subject to rolling COVID measures, which has upended our lives. Protocols which were proposed as only temporary reactions to incomplete medical data are firmly still in place. For example, it's reported that almost 2/3 of large school districts are still requiring students to wear masks. This is despite a much clearer picture today on the risks faced from COVID, as well as the negative side effects to kids from COVID measures like lockdowns, social distancing, etc. I think the staggering mental health numbers show that our children have borne the brunt of a flawed policy process where trade-offs aren't considered and consequences aren't discussed. Anything that drastically alters the routine and normal life for millions of children must be strongly scrutinized to consider the trade-offs and long-term cost. For example, why are children as young as 2 years old still being mandated to wear a mask in many daycares and on airplanes? What does that really accomplish other than to impact their development? But far too often in Washington, complicated and unrealistic solutions are proposed when the simplest solutions will do. The solution here is simple. We need to return kids back to normal. They must be in school without unpredictable shifting COVID protocols that make learning and living unmiserable for them. This is what the American people want. Recent polls showed that 70% think it's time we accept that COVID's here to stay and we just need to get on with our lives. I think parents are rightfully upset at the current COVID policy regime that's being enforced. They're worried about being bullied and canceled for questioning continued COVID measures, even though their children are facing mental health consequences. I fear the current wave of mental health issues that we face today will only worsen if we continue down the same path of never-ending disruptions. Ms. Saucer, in your testimony, you very clearly laid out the impact of caseworker burnout and how the pandemic has caused a rise in severity of cases. Based on the experience, do you believe that the cases and caseworker burnout is exacerbated by the reduced number of mandatory reporters due to some of the school closings and virtual learning? Do you believe that the impact's severe enough that we need open schools so that each children have more eyes on them and have access to intervention early on?
Thank you for your question. And education is not my area of expertise, but I'll do my best to respond to your question. I'll say in Ohio that we have about 600 plus school districts. They're now open, and it does not appear that many, if any, of our school districts will go back to remote learning on a widespread basis. Give credit to our two state departments, Department of Education and Job and Family Services. They did work very closely together when we did have to go remote, and they ensured that between the schools and children's services agencies, we would maintain services to families. We provided laptops so children could learn remotely. We offer pandemic childcare to families. Wi-Fi access was expanded to so children can learn remotely. And in terms of child welfare and the impact on remote learning, we did see a reduction in referral and screening cases in the early part of the pandemic, but a report that we issued last September showed that we quickly began climbing again when schools went back into session this fall. And that we were actually back to pre-pandemic levels when it comes to screening and referrals. So we don't, at least in Ohio, assume that our mandated reporters aren't doing their job. They are. They're making referrals to our county children's services agencies, and we are responding appropriately. I will say the pandemic took a toll on our workforce. While many people were able to work from home, our workforce had to go out into families' homes. They had to do investigations. They had to ensure children were visiting with their families. They were transporting children, et cetera. So they definitely took, the pandemic had a toll on our workforce. Thank you.
Thank you. I'm about out of time. I know we wanted to talk some more about substance abuse and not just opioids, but other such as methamphetamines and others that are affecting us as well. But recognize that's some things we need to talk about. Mr. Chairman, I yield back.
Thank the gentleman. Let me recognize the gentleman from Illinois, Mr. Schneider, to inquire.
Thank you. Thank you, Mr. Chairman, and I want to thank our witnesses for joining us here today and sharing your important perspectives in your testimony. Americans were experiencing a mental health crisis long before the pandemic overtook the nation, intensifying the burden, but also bringing to clear light the breadth and depth of the challenges we face. I'm not an expert. I may be using terms not precisely as medical professionals do, but I know quite well that mental health issues, including depression, anxiety, substance use disorder, self-harm ideation, social isolation, and many other diagnoses, do not discriminate. Mental health needs cut across all ages, geographies, races, ethnicities, and income levels. As a nation and as our nation's elected leaders, we need to work assiduously to understand all facets of this crisis. And we have to make sure that we craft policies that serve all Americans where they live within the context of their own individual experiences. We need to eliminate social determinant barriers, especially in vulnerable communities that contribute to health challenges in general and mental health issues in particular. This committee has a responsibility to ensure public confidence in our healthcare institutions and that we work to provide comprehensive, equitable, and quality care to all Americans, including care for their mental health needs. Gaps in our systems can have a tragic consequence. I have a heartbreaking example that highlights our unmet behavioral health need. One of my constituent families lost their son to suicide. Jeff was a Metropolitan Police officer dispatched to the United States Capitol on January 6th, who suffered injuries both visible and not in defending us on that day. His father shared that those injuries and the combination of the stigma around mental health and the lack of access to care contributed to their family's terrible loss. We can not only save lives, but we can give people the chance to live full, enriched lives if we improve our mental health system and empower all Americans to access the care they need. We need more mental health awareness, better education to increase awareness and remove stigma, and smarter reimbursement policies for mental health services. We need many, many more trained mental health providers for both adults and children, and we need to support our providers to protect and nurture their own bodies, minds, and spirits. Two areas of concern that I'd like to highlight today are the mental health burden on Americans' healthcare workers serving on the front lines and children's access to behavioral health services to address the pandemic's long-term mental health impact. I've heard from frontline healthcare providers in my district about the high staff burnout, depleted morale, and funding and reimbursement challenges. And I've heard from the Ann and Robert H. Lurie Children's Hospital of Chicago about the severity of the pediatric mental health crisis as a consequence of the pandemic. Suicide attempts have gone from a pre-pandemic level of 2 to 3 a month to 2 to 3 per day. Prior to the pandemic, Lurie Children's Hospital used to get 50 calls per week and for new appointments, and now that is their daily average. Staff continue to be overwhelmed by the relentless pace and the workforce shortages. So if I can start, Dr. Powell, and let me first say thank you for sharing your personal story, and I pray for your niece. My question is, are the mental health professionals at University of Connecticut Health experiencing the same high stress conditions and staffing shortages that I'm hearing about from my hospitals at home?
Absolutely, and thank you for your comments and for the prayers for my niece. I would say this, that clinician burnout is affecting almost every sector, state, locality, and group of providers that I've interfaced with. And I serve on a number of national and international boards. And so I can say with confidence that this is not an issue that's limited to one state. And what's more challenging about these burnout issues is that we're expecting our frontline healthcare workers to leap over these issues in a single bound, and they're not superheroes. I think that we have to recognize that the care that we so desire for every citizen in our nation should also include those who are doing the caring work. Healing providers are suffering. We've seen a lot of physician suicides, one, pretty prominent and highly profiled suicide of a healthcare worker, of a physician. And I think that we have to pay attention to those signs and signals that the treaters, the providers, the healers are not well. we can do better by them by instituting a system and a command climate that actually encourages radical self-care. We do a lot at our particular institute around these issues. We actually have a Mind Day on Fridays where our workers are encouraged to have a flexible work day to take care of those things that they haven't had a chance to get to, and more importantly, to be off of Zoom and WebEx so that they can reduce the Zoom fatigue that they're feeling. I think there's a lot we can do in our immediate and proximal environments to create a culture of caring, to show our healthcare workers and folks that are sacrificing themselves daily that we care about them, that they matter. And I think that signal can come without a monetary, investment. That's just what you do. You care for people who serve others.
Thank you, Dr. Powell. And I'm out of time, but let me just share that last year I reintroduced the Social Use Disorder Workforce Act to increase the number of residency positions for graduate medical education payments under Medicare for hospitals to work on addiction, psychiatry, and pain medicine programs. And I look forward to working with my colleagues, trying to bring this bill forward, trying to bring relief.
Thank the gentleman.
As we've talked about throughout this, there's much more to do. And I thank the chairman for the time, and I yield back.
Thank the gentleman. The gentleman from Pennsylvania, Mr. Schmucker, is recognized to inquire.
Thank you, Mr. Chairman. I'd like to thank all of the witnesses for testifying here today. COVID-19, as has been talked about, has certainly exacerbated the mental health challenges faced by our children. And of course, that's why we're here today. And I appreciate the chairman scheduling this hearing. I am concerned that some of the responses taken to combat COVID-19 in schools, while perhaps well-intentioned, may have made the problem worse and not better. Despite almost $125 billion spent in the American Rescue Plan Act last year to keep schools open, and President Biden's vow to keep schools open, many schools closed again this winter amid Omicron outbreaks. And I was chair of the Education Committee in the State Senate in Pennsylvania. One of the things we worked with our school superintendents was to combat what we call the summer slide, or the summer loss of learning that students tend to experience. And by the way, particularly students who are historically disadvantaged student groups see the most impact from not being in an education setting. And so, teachers we've known this for a while, teachers noticed that students coming to the school in the fall had lost, were at a different academic level than when they had left before the summer. And so looking for ways to combat that. So I'm very, very concerned about the long-term impact on students of the loss of learning from schools that had been closed on and off over the last 2 years. And then certainly we need to also address a child's mental health needs while they are in school. And I particularly want to talk about masks. I know that's been brought up earlier several times in this hearing. But I was pleased to see in Pennsylvania, the Pennsylvania Supreme Court threw out Governor Wolf's statewide mask mandate for schools earlier this month. And the reason I'm pleased with that is because, first of all, the data of the effectiveness of mask wearing in schools is not in question. Is in question, I should say. There's not a body of evidence that supports that mask wearing in schools for students is effective. And to that point, Mr. Chairman, I would like to submit for the record an Atlantic article that was published last week, published on January 26th, titled "The Case Against Masks at School." I think you should have that at your desk.
So ordered.
Thank you. So again, it's titled "The Case Against Masks at School." The subtitle says, "Districts should rethink imposing on millions of children an intervention that provides little discernible benefit." And this is authored, by the way, by an infectious disease scientist, by a faculty member at the Portland State University School of Public Health, and by a doctor at UCSF. And they point out in the article just a few things I'd like to point out. I think it's a pretty good synopsis of what we know about mask mandates so far. But they point out, as I mentioned earlier, that there's little conclusive evidence that masking in schools reduces COVID-19 transmission, but points out that mask requirements in schools do come with risks. And I feel We don't balance enough some of the risk with the mitigation efforts compared to the risk of COVID. For example, they say requiring masks may impede children's hearing communication, their language and speech development, and their emotional recognition. Furthermore, masking presents even more drastic challenges for children with learning disabilities. Other countries, like the UK, Denmark, have caught on to this, by the way. The World Health Organization guidance urges that children under 5 and children with developmental disabilities not be required to wear masks, and that masking decisions for children should take into account children's psychosocial needs and development milestones. And alternatively, here in the US, the CDC guidance recommends that all children age 2 and older wear masks without any nuance or any acknowledgement of the potential risk that masks pose for children. So, just my sense that masking decisions should take into account the overall well-being of children. And as we've seen throughout the pandemic, I think a one-size-fits-all approach rarely works. So, Ms. Avula, I know you've spoken to this previously, but how have school closings impacted the mental well-being of children? And what challenges do masks bear on children's learning and development?
Sure. So school closings, I think, have impacted considerably the mental wellness of children. As I mentioned earlier, I think young children, particularly adolescents, they really crave socializing, and it's part of their growth and development. I think for us, if we think about adults, if you went from age 37 to 39 or 41 to 43, that's not that big a difference. But if you left in the 6th grade and returned back in the 8th grade, or in kindergarten and return in 2nd grade, that's a huge difference in a child's life. And those years are very, very important. And then children will have a consequence to that. I think it's very important to consider whether you're considering masking or other mitigation strategies. I think all of it has to be balanced with overall wellness for sure.
Do you think that policymakers have appropriately balanced the risk of COVID-19 with the negative impacts of school closures and masking?
I think that there definitely needs to be more consideration. I think there are some policymakers that have had behavioral health people at the table. I think that's also very important. It's who you have at the table making these decisions and considering all aspects. I think some policymakers have. I think across the board, can we say that this has been, balanced? I don't think that we can say that. And I do agree that in 2020, when this first came about, maybe there was a need at that time to do certain things because it was just so new. We are in a different place now, and I do think this warrants more conversation about balance.
Thank you.
Agreed,
Thank the
and thank
gentleman. Let me point out that
Thank you,
the House is about to entertain votes on the floor. It is the chair's intention to proceed to get through the hearing for good and obvious reasons based on the superb testimony and questions we've heard. Gentleman from California, Mr. Panetta, is recognized to inquire.
Thank you, Mr. Chairman. I appreciate that. And thanks to all of the witnesses for your time. Talk about Zoom fatigue, but nevertheless, you endure. Thank you, as we have throughout this pandemic. Thank you guys very much. Obviously, as we've heard and as we know firsthand, this pandemic has taken a toll on our nation's mental health, and it has had a particularly alarming impact on our frontline healthcare workers, our teachers, and our children. I have 2 daughters of high school age. They stayed at home for about a year and a half. They absolutely owned it academically on Zoom, but let me tell you, it was time to get their butts back to school because you saw it was affecting them. There's no doubt about that. Now, we know that our kids still suffer, though, and younger children have missed valuable social and emotional development time with their schoolmates, and older kids have missed major milestones. To mitigate those impacts, though, it's clear that we in Congress need to address this issue head on with more resources for those in need. And that includes resources that we provided in the appropriations bills that passed the House, including $1 billion that I champion for mental health professionals in schools. Now, my first question is to Ms. Salser. What other resources do you think beyond that should Congress provide reasonably to assist our children?
Thank you for that question. I'll answer it obviously from a children's services perspective. So as my testimony showed, we in Ohio, but similar to other states, are really experiencing a challenge of finding services and placement options for children who have very significant mental health issues, also could be developmental disabilities, or also involvement in the juvenile delinquency system. And so I'll go to prevention first. We, like all states, are working aggressively to implement family first prevention services. We want to keep kids out of foster care. That is our goal. We know when children come into foster care, they suffer trauma, and the likelihood of them going home reduces every time, the longer they stay in care as well. So we want to keep children out of foster care by providing evidence-based services. The challenge that we have in Ohio, and I'm sure other states and counties have this as well across the country, is that we just don't have the capacity of providers today to implement those evidence-based practices that the federal clearinghouse is rating. For kids who have to come into foster care, we want to stabilize their needs as quickly as possible and find the right placement for them. Unfortunately, when kids come into care who have very intense behavioral health needs, mental health needs, we struggle with finding an available placement. We at times may call 51 to 100 providers until we find a placement. And then if we do find a placement, we could have caseworkers traveling 2-3 hours away from that child's home, away from that child's friends, from that child's school. And we also know the further away a child goes from their home county, the less likely that they will return home soon. So it's a huge challenge.
Great, thank you. And I just got one more area I want to hit on. And Director Avula, I want to pose this to you. Obviously, with the isolation that many people had to endure, that has led to substance abuse, and not just alcohol, but harder drugs like fentanyl. And I want to know if you can kind of hit on why has this isolation led to this type of serious drug abuse, and not just alcoholism, but like leading into these fentanyl and those types of drugs that really just kind of do the extraordinary things to people that we've seen. What's going on there?
Well, often if individuals are seeking to use substances, they often are feeling that they can't take the stress any longer, whether it's the stress of isolation, the stress of loneliness. Social engagement helps mitigate stress, and there was not that level of social engagement that people were able to have during the pandemic.
And so they had to go to fentanyl? I mean, why did it have to go that steep?
Yeah, I don't know that people necessarily seek fentanyl. I think the issue is as addiction progresses, you look for what can give you the next high, right? And I think that's what the issue is. I don't know that an individual who has never used a substance is likely not going to start with fentanyl. I think there are things that may lead a person there ultimately, particularly if they have an existing substance use disorder. And in many cases, they're only, and this is going to sound strange, but the only contact people had during the pandemic was potentially with their drug dealer. That was something we were hearing in communities. People weren't connecting with other people, but people were able to find the source of their substance.
Thank the gentleman.
Thank you, Mr. Chairman. I yield back.
I thank the gentleman. The gentleman from Oklahoma, Mr. Hearn, is recognized to inquire.
Thank you, Mr. Chairman and Ranking Member Brady. I really appreciate the opportunity to be here today. I thank you for hosting this hearing today on America's mental health crisis. Right now, our country is also facing an inflation crisis, a border crisis, an energy crisis, and multiple national security crises. Many of these issues are within our jurisdiction. It's time this committee met to address the crises that are affecting all Americans every single day. We now have the data to prove that shutdowns, lockdowns, and social isolation have drastic long-term effects on mental health. My previous friend there, colleague right there just spoke about it, Democrat from California, and Mr. Panetta. I really appreciate him acknowledging that. The Biden administration's ever-changing COVID strategy only adds to the stress and uncertainty that all Americans are already feeling. Biden signed a mask mandate executive order during his first week in office, then lifted the mask mandates 3 months later, then reinstated them 4 months after that, and another 4 months later, he issued a vaccination mandate on top of it all. Vaccine mandates put further stressors on individuals who are forced to make a choice between their personal health and their paycheck. We are more than 2 years into this. It's long time past to provide Americans with certainty and stability and stop promoting isolation, which we know exacerbates the mental health crisis facing our country. Let's look at the facts. A study from the university psychologist confirmed what many of us have said all along. Lockdowns and school closures not only increase depression, loneliness, anxiety among children, but they also isolate vulnerable students from needed interactions with teachers, faith leaders, and community members who are trained to notice when a child or adult is exhibiting signs of mental health issues. Since schools closed and children were forced into isolation from their peers, we've seen a 30% increase in teen mental health related emergency department visits and the highest number of overdoses ever recorded in a 12-month period. The numbers don't lie. We know what's working and we know what's not. It's clear that mental health is a growing issue, and I want to talk today about the technology that has opened a new frontier into mental health support. In 2018, Congress passed the Support Act, paving the way for seniors to access virtual health consults for mental health issues. Telehealth, or as I call it, virtual health, has become even more popular during COVID-19 pandemic, with more than 52 million seniors utilizing telehealth, a 63% increase, because of current regulatory flexibilities available under the pandemic. Unfortunately, this committee has done no work to keep those virtual healths an option for seniors post-public health emergency. It's time for us to begin the tough work to make virtual health flexibilities permanent. Our employers have made the virtual workspace a permanent fixture. We should be doing the same with our medical care. We need to figure out how much to pay health providers for virtual visits and come up with a plan to pay for these benefits without bankrupting the already financially unstable Medicare trust fund. Ms. Avula, thank you for your testimony. And in my remarks, I highlighted the success of technology and virtual health during the pandemic. As other industries like banking, clothing, and food excel in the digital space, consumers are increasingly expecting a digital healthcare experience to match the rest of their lives. So my question to you is, in addition to the virtual visits with healthcare providers, is there any other technology Congress should look at as a resource for mental health, like therapies on phone applications? And then a second part of that question would be is, what role should these apps play in digital therapeutics today?
Yeah, thank you for the question. I think it was mentioned earlier about an app that was developed by teenagers. I think absolutely the use of apps and technology-based care can really be of great assistance, particularly to reach young people. Absolutely, I think that should be looked at. SAMHSA also recently put out a psychiatric advance directive, which is available via app. So that, again, is a means of connecting with the healthcare system in a different way, but being able to have individuals with serious mental illness identify what their needs would be if they were in a mental health crisis. I think utilizing technology of any kind to advance care, utilizing technology to develop virtual support groups, virtual peer groups, again, this will be a real way to engage our youth. It is also a very, very good way to help train and educate providers. Technology has been used quite a bit in that realm, and I would like to see that continue as well.
Ms. Avula, I appreciate your expert testimony, and thank you, Mr. Chairman. I yield back.
Thank the gentleman. Let me recognize the gentleman from Michigan, Mr. Kildee, to inquire.
Thank you, Chairman Neal, for holding this really important hearing today. I want to take a moment to share a story about one mid-Michigan family's mental health crisis and their heartbreaking journey to find help. About a year ago, Jay Gross, a father, husband, teacher in mid-Michigan, sat in the hospital parking lot feeling like he was at the end of his rope. For 12 days, his son had been stuck in the emergency room in desperate need of mental health services, while Mr. Gross tried desperately to find his son a pediatric inpatient psychiatric bed. The Gross family left no stone unturned, worked with their private insurance company, worked with Medicaid to try to find a bed in a mental health facility, only to keep hitting roadblocks, being told that there was no spots, or being told that their insurance wouldn't work where there might be a placement. As he sat in that parking lot, Mr. Gross recorded a video pleading for help for his son. And the pain, I watched that video, the pain he felt jumped through the screen. And the injustice of his situation connected with people. Hundreds of thousands of people saw that video on YouTube. And then his son finally was moved to a mental health clinic the next day. Mr. Gross and his family and people like that family should not have to go on social media to plead for care, and their son should not have had to wait 12 days in an emergency room while the crisis is ongoing to get the help that he needed. Asking parents to navigate the complex pediatric mental health care system is tough enough when they're experiencing some of the scariest moments and sometimes literally fighting for their child's life. It's completely unacceptable. So for families whose children are in the middle of an acute crisis and who struggle with mental illness, the journey to find care and therapy is daunting, and that's just not acceptable. Reports indicate that during COVID-19, depression and anxiety, has been said, is up. My first career before I came to Congress was in the child welfare system as a child welfare worker. And I know how stressful this whole environment can be. So to start, just two questions maybe Ms. Saucer could respond to. One, how has this pandemic impacted the child welfare workforce? What can be done to prevent their burnout? And secondly, probably more importantly, what short and long-term investments do we need to make at the federal and state level to meet the mental health needs of our kids? Can you address those two issues?
Thank you for your question. I'll start with the first one. The child welfare workforce, as you mentioned, Representative, is always challenging and stressful. And before the pandemic, we obviously had the opioid epidemic, and that brought a lot of secondary trauma to our workforce. And then we added right on top of that the pandemic and our workforce having to navigate those challenges, but continue to meet state and federal mandates in ensuring that children are safe. So it has added to the stress of our already overburdened workforce. We are seeing, unfortunately, workers leave because they can get higher paying jobs that have a lot less stress than child welfare. So we definitely want to work with this committee to look at how we could achieve flexibility within Title IV-E admin funds, so we could increase supports and services to our workforce to address their their secondary trauma and ensure that we can retain those workers. We also are interested in using Title IV-E funds and Title IV-B funds to increase training opportunities to students in higher education settings to get them encouraged in the child welfare field so that when they graduate, they can become a child welfare worker. So the more we can invest early on in getting students interested in this field, the better. So we have a career path for our workforce because we absolutely need it due to our turnover issue. The mental health challenges facing our children is a very complex issue. I think it's been mentioned before that the mental health system is fragmented, and we need to all work together to build a very comprehensive, coordinated system of care for children. Families should not have to make the decision whether to relinquish custody of their children to child welfare just to access mental health services for children. We need to do a better job for our children and our families. Thank you.
Thank you so much.
Thank the gentleman.
Mr. Chairman.
Thank the gentleman. Let me recognize the gentlelady from West Virginia, Ms. Miller, to inquire.
Thank you, Chairman Neal and Ranking Member Brady, and to all of the witnesses for being here today. Ms. Saucer, your comments really resonated with me in your testimony. Ohio and West Virginia share more than just a border. And I know the experiences of our citizens throughout the Ohio River Valley have so many similarities. We're nearly 2 years into the COVID-19 pandemic. With every new variant that rises to the surface, there are constant looming threats of reverting back to the isolating lockdowns that occurred in March of 2020. We've already completely shut down our economy, and children weren't allowed to go to school or interact with other people, with their classmates, their teachers. So if you were lucky, your work went home and went remote. However, there were millions of Americans that just plain old lost their jobs and their livelihoods. Between April 2020 and April 2021, there were 100,000 drug overdose deaths nationally. an increase of nearly 30% from the previous year. 1,600 West Virginians also lost their lives. Thanks to a historic investment from Congress in the Support Act and your work with SAMHSA during the Trump administration, we were finally starting to turn the corner in addressing the opioid crisis prior to the pandemic. However, the COVID-19 public health emergency really set us back. As we emerge from this pandemic, we've got to evaluate the effect that a constant lockdown has had on our patients. Earlier, my colleague spoke about the open border and how this was enabling drugs to pass freely. So wouldn't you say that the forced lockdown of our economy was directly impacted those people with addictions? I'm asking that of you, Ms. Avula, sorry.
Thank you. No, that's okay. Thank you. Yes, I do believe, so there is data, pre-pandemic data that absolutely correlates loss in employment to increased mental health challenges, increased substance use disorders. Financial instability is also one of the things that impacts both substance use disorder and mental health challenges.
You know, you talk about 1 out of 10 Americans that have substance abuse disorders are receiving treatments. As we emerge from the pandemic, what can Congress do to close the gap?
It's a great question. I think, again, we really need, we need additional resources that are flexible, that are tailored to local jurisdictions, kind of needs. But I also think we really do need an all hands on deck approach. And again, what I mean by that is it cannot just be the specialty addictions field that addresses this. I think we need primary care, we need care integration, we need peer support. One of the other things in North Carolina we are doing, which I think is very, very important, is a healthy opportunities pilot looking at non-healthcare services. So housing, employment, food stability. I think all of those things are also essential to being able to get people proper care and treatment so that you don't, if they are one of the 10, that you don't see them again, that you actually want to give them care and treatment and recovery support services in the community to achieve recovery.
So you're saying that Congress should work hand in hand with the states in order to have the flexibility, basically, right?
Absolutely. Yes, absolutely. I think one of the things that would greatly benefit states is if funding came without super severe restrictions that we're not able to use it in the way that we need. So West Virginia's needs are going to be different than New York's needs, are going to be different than North Carolina's needs. And the people in your state, they know those needs best.
And that brings me to the use of telehealth and how it will help patients to receive access to care. And so don't you think that that is a good idea as well, as to do whatever we can to help with telehealth?
100%. Yes.
Okay, thank you. Mr. Chairman, I yield back my time. Thank you.
Thank the gentlelady. Let me recognize the gentleman from Nevada, Mr. Horsford, to inquire.
Thank you very much, Mr. Chairman. This is an incredibly important hearing on an unprecedented mental health crisis that is affecting so many of our neighbors, family, and friends. And I want to start by saying that the pandemic has aggravated this issue, but this is an issue that existed well before the pandemic. And so while my colleagues unfortunately want to make this about politics, we really should focus on the people who are directly affected. We should all be concerned at the low rates at which Americans, particularly Americans of color, are able to access and receive mental health treatment. It is crucial to understand that individuals in need of professional mental health resources are not to blame for their inability to get treatment. In fact, it's our healthcare system, and unfortunately, elected officials that have failed 54% of adults with mental illness. So I'm hopeful that we can actually, again, focus on the people that this policy will benefit and not politics. Part of why we are woefully unprepared to handle the present and future mental health crisis is simply because we do not have holistic or accurate data from historically underserved communities. And without data it is impossible to know how many individuals within our communities are in crisis every day, and even more importantly, it becomes exceedingly difficult to understand what the mental health workforce needs to look like going forward. Lack of access to mental health care and a fundamental misunderstanding of the prevalence of mental illness only serve to further the stigma around receiving mental health treatment. I've heard from many of my constituents that the most helpful interventions center around outreach and stigma reduction. So we need to ensure that a negative societal stigma does not prevent an individual from accessing services. And I believe that change must come from within communities. We need to begin preparing the next generation of mental health practitioners today, or else our children and those who are in need of services will continue to struggle with this crisis for years to come. Dr. Powell, thank you so much for your testimony. I certainly agree that training students for careers as mental health providers is crucial to reduce treatment disparities. Do you believe that the best mechanisms for these training programs is to partner with existing programs at historically Black colleges and universities, MSIs, and Hispanic serving institutions? Or do we need to establish independent programs in areas that are currently lacking efficient staff pipelines?
I really appreciate your perspective, and I think you're spot on in recognizing that partnering with historically Black colleges and universities and Hispanic serving institutions, et cetera, are going to be a primary way that we can fuel and retain a diverse, equitable, and inclusive workforce. But as you so mentioned, that's not the only strategy that we should be utilizing, because we also have not just a pipeline challenge on the back end, we have a front end problem where we lose a tremendous amount of the potential talent in the pipeline earlier in their educational journeys. So we can't just rely on those strategies at the output side. We have to also look at the inputs. And we need to think about, how do we cultivate leadership development and training programs that encourage students from these historically excluded populations for pursuing these careers. We have a diminished number of men in the mental health care workforce. Why aren't we working on programs that are gender inclusive and responsive, that encourage young men and boys, particularly those from historically excluded communities, to participate in the field? So you're right, we have to leverage all of those points of access, but partnering with HBCUs and MSIs and Hispanic serving institutions is extraordinarily important in this moment in time.
Thank you. I know I'm out of time. I will just submit some other questions to Ms. Avula regarding how we can ensure that telehealth meets all of the needs, particularly in rural areas. Beyond just internet access, we also have a lack of providers, particularly in mental health services. I represent 5 rural counties in Nevada, and that is one of the biggest barriers to people accessing care.
Thank you, the gentleman.
Chairman.
The gentleman from North Carolina, Mr. Murphy, is recognized to inquire.
Thank you, Mr. Chairman. I appreciate the warm welcome to the committee, and I look forward to working with everybody. I've been blessed for the last 30 years to be a practicing physician. In fact, I still am. I still see patients, still operate. And so I have seen firsthand so many of the issues that we faced with mental health in our emergency departments, in our hospitals, in our clinics, and it's tragic. The system that we face is tragic right now. I recall now, someone was talking about pediatric patients in the emergency department. I recall a couple years ago we had a child in our emergency department, I believe was 14 years old, that sat there for 56 days, taking up a bed, that we did not have access to resources for that child. That's tragic. That should not be happening, and it definitely needs to be addressed. I also want to talk about not enough doctors, not enough clinicians, psychologists. Without a doubt, we are in a massive shortage. I'm in the most critically short surgical specialty in urology. We're going to lose half of our individuals now are 58 and older, a third are 65 and older. We're going to hit a precipice very, very soon. That isn't filled by adding mid-level providers, nurse practitioners, PAs, which do a fantastic job, but they are not physicians, they are not surgeons. That's not how we fill this. And I applaud my colleague, I apologize, I can't remember who that was, that wanted to increase GME money. It's long since overdue. One thing I would tell you is one of the problems that we're having in the physician workforce is that people graduate from medical school and then they don't become practicing physicians. They choose other lines of work, or they stay at home or do other things. And so I think adding that money to GME is great, but let's put skin in the game and make sure the people that were graduating from medical school actually stay and practice medicine. That would truly, truly help our problem. I've seen so many of the issues, obviously, of the past year that everybody has talked about ad nauseum, about lockdowns, about masks, about forced vaccinations. You know, at first we didn't know what we were doing about this, and all those things were 100% the right thing to do. Sadly enough, over a year ago or so, politics finally took over. Where we're shaming people that are not wearing masks, and we're shaming people who are not vaccinated. We're closing businesses, throwing people into unemployment and depression because they're not following certain rules, because the rules sure as hell don't follow science. And that's caused a massive tragedy to us today. And sadly enough, while we were building a ship, while flying it, we could have corrected things easily over this past year. Unfortunately, this administration has not, and it's further and further divided our nation. So we're faced now with a major problem in our mental health issue, one that has spiked in overdose uses. I worked a lot when I was in the State House on our opioid epidemic, and we made great strides. But sadly enough, with our porous southern border and increased demand because of depression, now we've seen 100,000 people die from overdoses. It's a tragedy. That should not be happening in this country. So I could go on and on just about personal experiences, but we have wonderful witnesses today whom I'd like to thank for coming and sharing their testimony. I do just have a couple questions because, you know, things that we do in this government actually have results. They have consequences that, that now we're having to deal with. So actually, Dr. Powell, if I could address a question. And I'm going to ask you, you know, in 1965, the Great Society programs came out. And I just wondered what your thoughts were is, what do you feel that the breakdown of the nuclear family has done on the crisis of mental health issues for children?
So I think it's really important for us to acknowledge that, as you have lifted up so importantly, that families play a critical role in ensuring that youth develop positively. But I think we've also, in our, inclination to think about family structures in our past and present, we have unduly, I think, pathologized families that are poor, that are operating with matriarchs at the head. And we have not considered all of the other social factors surrounding those families that give rise to poor mental health. So I think family systems and strengthening the family, we have to absolutely continue to do as a nation if we're going to get our arms wrapped around this problem. But families don't exist in a vacuum. Our families actually exist.
I'm sorry, Dr. Powell, I kind of spoke too soon or too much, so I don't have much time, but I thank you. I appreciate that. I always, when I see young children and a single mother, I plead with that mother to read to that child. I plead with them to try to find a father figure in that life because it means so much, not only to young men, but to young women. Quickly, I'm sorry, Ms. Avula, quickly, just in North Carolina, how can we help address the opioid epidemic and the number of individuals that are now dying?
Yeah, thank you for the question. North Carolina has actually done, as I'm sure you were aware, an amazing job with its opioid action plan. One of the things that North Carolina was able to do was to keep its OTPs open, and we saw an increase in individuals getting care and services in opioid treatment programs. I think one of the things we will continue to do is look at expanding those programs, looking at expanding medication-assisted treatment in jails and communities, and also looking at prevention strategies. We're also doing a number of things in communities to prevent opioid use disorder, and we will need to continue to do that. And we've got resources from the federal government. Any additional resources would obviously be put to very good use.
All right. Thank you. I went over my time. I appreciate your counsel today.
With that, let me recognize the gentlelady from the Virgin Islands, Attorney Plaskett, to inquire.
Thank you very much, Mr. Chair, and thank you to the witnesses for giving so much information to us and sharing your expertise, and for the questions of my colleagues as well. I've learned quite a bit in this discussion. Ms. Powell, Dr. Powell, you spoke, I saw you nodding your head when one of my colleagues was discussing the need to have additional healthcare workers in the system. My colleague also, Mr. Horsford, talked about the need for creating pipelines for that. What are some other things that we as members of Congress can do to try to increase that number, particularly in those communities, whether they be rural or communities of color that are in desperate need to find incentives to bring people into those communities?
Thank you for the question. I think that we need to really reaffirm our investments in the kinds of training programs that actually do that important outreach to first generation students, to students who speak English as a second language, and all individuals who occupy historically excluded social identities. We have a tremendous opportunity here with some of our existing programs to continue to support them. I myself am a recipient of the American Psychological Association's Minority Fellowship Program. Without that program, undoubtedly, I would not have been able to enter graduate school and successfully pay for it as a first-generation student raised by a single mother. I do think that those programs matter, and I think that we have to reimagine what they look like in this iteration, but continue to invest in them. And then we also have to work on the environments in which, the training environments in which students of color often matriculate and occupy. The challenge that we lifted up earlier about students leaving medical school and not going into practice is a similar thing we see with historically excluded individuals in graduate programs. Those environments are sometimes toxic and traumatizing, and those environments lead to an attrition from the workforce.
Thank you.
So we have to incentivize those structures. Yes.
Thank you. The other issue I wanted to ask you each about, starting with you, Dr. Powell, and if we have time, any of the other witnesses who might want to discuss this. So many of us here on this panel, so many of us here in this committee, so many members and so many Americans have dealt with mental health illnesses in their own families. I consider myself to be, and maybe very educated, overly educated individual. And yet I did not even as a parent see the signs of what mental health were in one of my own children. I just, chalked it up to them not working hard enough, them not pulling themselves together, them being, oppositional, rather than it being depression, rather than it being anxiety, rather than it being true mental health that my son was dealing with. And I wanted to ask you if you could share with us some of the ways that Congress can support communities and education in schools so that parents and teachers can identify those children that are in need. I think about my son as an African-American boy and then young man dealing with mental health, and the concern that parents have that their son will get caught up in incarceration, where the police may pick them up thinking that it's a criminal activity when in fact it may be mental health. What are the ways that we can identify these issues earlier so that we can support our young people?
The first thing we have to do is listen to our children, and not just listen to them in the traditional ways. We say often in my field that we have to listen with a third ear. And that means listening to the signs and symptoms, not just with an ear around discipline. And that's often the challenge with particularly children of color who face extreme adultification biases. That is, that systems see them as adult long before they actually have reached maturation, and they expect them to, again, leap over these symptoms and experiences, like superheroes. So we have to first acknowledge that we have those biases, and then create the kind of education and awareness campaigns in schools that engage parents first, that actually include them, because often the parents at home are often suffering sometimes from the same symptoms. So we have to move away from this sort of treating the child only to treating the whole family system within the school. And the other thing is to really watch out for the signs and symptoms that show up as disciplinary problems, and ask ourselves not just what's wrong with this child, but what's happened to the child.
Thank you. I think we've run out of time. But I want to thank all of our witnesses for joining us today. And please be advised that members have 2 weeks to submit written questions to be answered later in writing. those questions and your answers will be made part of the formal hearing record of this hearing. With that, the committee stands adjourned.